Hi.
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 Oh, I've shared my screen now. I can't see anybody or anything.
Oh, no.
I don't like it when it does that.
No, it's not great, is it? Just managed to finish clinics. I'm relieved. Just done.
Oh, bless you.
Have you started the recording, Terry, already?
It did it automatically when I was fiddling around with muting people and stuff. And again,
Ooh.
just have to remind people that it is, but I think it's really just the presenters, isn't it? So
Yeah, I don't think people will mind.
no. And all the presenters have been told, so they should be okay.
Yeah.
So Claire Boag, who's on at 2:15, she's sent me a recording through.
Oh, has she?
Yeah, so I think she's been affected by the strike today, but I think she's going to try and join. So she's just sent it just in case she can't.
Hi, Kate.
Hi, Kate.
I mean, hi. Now that I've got my thing on,
Oh, I can see it.
I'm working from home and the heating's on full blast and it's freezing still.
My heating's broken, Kate.
Is it? Oh,
Yeah, I've got one of those condensing boilers and the waste just freezes. So, so it's just frozen. Anyway, I've got a little electric blanket around my legs.
Have you? I've just been upstairs to get one of the duvets off the kids' beds. So.
Well, I don't want to show off, but I'm in a really hot clinic room in Dewsbury. I am in a really hot. I'm boiling.
You're sweating.
You're actually wearing shorts.
I am. I'm losing weight as I sit here.
Excellent.
Yeah. It's like being in a sauna. It's all right, actually. It's really cold outside, but there's frost and everything. But it's nice and warm where I am. Sorry.
No, my brother sent me a load of photographs of him and his kids sledging, and I was like,
"Where's he living, Kate?"
Sheffield.
Oh, in Sheffield.
Yeah, it's only like 30 miles away, 20 miles away. And
Hi, Catherine.
Hi, Catherine. I think you're muted.
Hello. Are you
Quite quiet.
Yeah, quite quiet.
See.
There you go.
Alison, can I check that? Can you see the like a Holden page rather than my face?
I can see both your face. I can see your face and a Holden page.
All right. Oh, okay, fair enough.
It sounds disappointed. I'm not quite sure that you need to be.
Can you guys hear me now?
Yes, that's right, Catherine. Yes, lovely.
Have you guys, Catherine? Have you guys changed your case? Because
yes. Sorry, because I'm really sorry. Yeah, we're gonna talk about an aortic dissection.
Okay.
I think probably because the other patient was more like advanced mechanical support.
Okay.
And you know her because Shona Knight, the lady that came. So and then Ken mentioned, he said like, maybe that's not, that's advanced heart failure management. So he said that probably it's better to just talk about an easier case. So it's a very straightforward case.
Cool.
Oh yeah. Yeah, sorry, Justina is also joining. How will you okay. Yeah, to the surgeon's office, Okay. Otherwise we'll have some echoing.
Yeah. So the only thing we just need to do is really try and stick to time, because we're really tight on time. And I know poor Kate Gatenby's got to, she's doing the third talk, she's got to leave to go and watch her son perform. So
one of my colleagues in clinics is exactly the same. Son is singing in the same carol service as Kate's son. I mean, this is just this little world that we all live in together, isn't it?
Indeed.
Yeah. So we got clinic finished dead quick. Everybody's dropping like flies at Leeds Grammar, Kate, with Tori's been off all week.
I know there's been some horrible thing going around.
Yeah, horrible. She's been off all week. She'll not go back to school, I don't think, this week.
Yeah, only 1 day left, which is a good job because my children are rapidly running out of shoes.
Are they growing? Are they inconsiderately growing?
No, they keep coming home with only one of a pair.
Oh
no. And then, so I was looking to see if I could send them with one of one pair and the other one of another pair because they were broken, but it was the wrong one. So I ended up having to do some Velcro gluing last night.
Nice. Some crafting, some shoe crafting. Excellent.
Yeah. Hi, James.
Hi, James.
You all right? No.
Yeah.
Hi, Deepa.
You all right?
Hello.
Everybody?
You okay?
We're all scattered around Yorkshire, and it's interesting. James is in Sheffield today.
Oh, I'm in Dewsbury.
You have to go around the place, Sarah.
I do. I'm mostly Dewsbury on a Thursday morning, and then it's Pinders on a Tuesday afternoon, and then it's mostly Pinders. But there is a bit of travel, but it's all right. It's okay.
I hear there's lots more babies to be born.
The
concentration of babies to be born.
I'm not going to tell a fib, James. My hot week was busy. It was really, really busy. Yeah, it's very, very busy on delivery suite at Pinderfields because the Pontefract and Dewsbury birth centres have closed, so all of the deliveries get shunted through. So it is, and it feels it. Definitely feels it.
What's the annual numbers, Sarah?
6,000 a year. At Leeds, it was 5,000 each side. So while there was a greater overall number, it definitely feels like 6,000 a year.
Yeah,
but that's all right. You know, keeps your skills up.
Yeah.
And there's a nice coffee shop downstairs, so that's always helpful.
That's good. Nicer than Costa or whatever it's now called.
Fontanella. Yeah, that's not difficult though, Kate, is it really?
It's just got the world's worst name. It's like,
well, I know it's
not very catchy, is it? Should we nip to Fontanella for a cup of coffee?
No, it's a hashtag no from Dr. Winfield. No. Yeah. No, I've got my own sippy cup. I'm ready.
Excellent.
Yeah.
Have you got your slides ready, Sarah?
Yeah, they are. Yep, I've got them here, and then I can share my screen in a bit. So just need to.
Terry, do you want to make us do an introduction at 1?
Yeah, if you do, because it's your course, so you do a quick intro and then I'll dive straight in.
Terry's done loads of the bits, so I don't know if you want to do it, Terry, or you want me to do it. Don't mind.
Yeah, I can do. Quickly.
I don't mind introducing myself, Terry. I don't mind at all because that just might be easier. I'm happy to.
Yeah, I'll do a quick welcome to everybody and then
I'll dive in. Okay.
Yeah, that'd be
sounds
great.
Good. Okay.
I had to send a reminder out through Eventbrite because on the Eventbrite, when you first get your ticket, it adds the login details right at the very bottom of this long ream of stuff. So
I've just put in the chat to add questions to the chat as people are speaking.
Yeah.
Okay.
Yeah. And Kate, let me know if you want to do a pause at the end of each talk, or do you want to just judge it on time?
See how we're going for time, I think.
Yeah. Okay.
Makes sense. Okay. Well, there's been a couple of apologies this morning, but there should be a few going. Starting to get going.
Hi, Kate.
Right. I shall start. Right, I shall make a start. I'm Terry Phillips. I'm the network manager for CHD at the in North East and North Cumbria. Thank you very much for joining us this afternoon. We'll have a range of people talking about heart disease and pregnancy, so I'll swiftly hand over to Sarah. I'll stop sharing.
Okay, I'm going to share my screen. Bear with me. Can everybody see my screen?
Yes.
That's perfect. I was going to do slideshow, but I often find that it's just easier to go through one by one. I'm Sarah Winfield. I'm a consultant obstetrician and lead for maternal medicine at the Mid Yorkshire NHS Trust. I'm the regional lead obstetrician for the North East, North Cumbria, Yorkshire and the Humber. And I've spent the last 10 years working with Alex, James and Kate Gatenby to in the obstetric cardiac clinic at Leeds. So I'm going to kick off today with Embrace and how important is cardiac disease. I think there's no greater way or more powerful way than using a service user's perspective. So an older diabetic woman with a family history of cardiac disease had IVF and multiple embryo replacement, and you can read this through. Her pregnancy was complicated by preeclampsia, and she had an extremely preterm delivery. And in the postnatal period, she developed arm and hand pain that didn't resolve. And she was found collapsed the following day and couldn't be resuscitated. There was a post-mortem and there was evidence of coronary atheroma and acute infarction. This was cardiac disease that this woman did not know that she had. This frames why many of you, I think all of you, are here today, that cardiovascular disease we know is the single leading cause of maternal death in the UK since the 2022 triennial report. We have a changing maternity population with increasing numbers of women getting pregnant later on in life, so they are naturally at greater risk of cardiovascular disease. And we also have higher numbers of women coming through every pregnancy maternity service with known cardiovascular risk factors, hypertension, obesity, diabetes. We're getting better at preventing maternal deaths from obstetric causes, which is good, but the overall mortality rate from cardiovascular disease has now been static with little evidence of change. More women die from cardiovascular disease in pregnancy than from all the direct causes added together, with the exception of thrombosis and thromboembolism. And there is clear evidence from every triennial report that the possibility of cardiovascular disease in women of reproductive age is still frequently not considered when they present with an acute problem. Many of you, all of you, hopefully will be familiar with the confidential inquiry into maternal deaths, which has in the last 10 years become the Embrace report, Mothers and Babies, Reducing Risk Through Audit and Confidential Inquiries. And the most recent report was published in November this year, which is very timely for this meeting today. A quick revision of maternal deaths and definitions. A direct maternal death is a death as a consequence of a disorder specific to pregnancy. That's hemorrhage, preeclampsia, sepsis, and suicide. Indirect are the cardiac disease deaths that are from previous diseases but are aggravated during pregnancy. And then there's incidental and late deaths. This is the document that many of you will be familiar with seeing, and we've been doing Embrace for the last 10 years, which is time out's really flown actually. I remember when it used to be the confidential inquiry. Each year a annual report is produced in a topic cycle. So you can see in 2016, cardiac morbidity and mortality, there was a heavy swathe of the report covered that, but as the years have gone on, it's been different things: morbidity from hemorrhage, breast cancer, PE, and then if you go down to 2022, you can see care of women with multimorbidity features highly. The word syndemic has been used in the most recent report. I had not heard of this, or I think I'd vaguely heard of it, but it means a situation in which two or more interrelated biological factors work together to make a disease or health crisis worse. So a syndemic or a synergistic epidemic is an aggregation of two or more sequential epidemics or disease clusters with biological interactions which exacerbate the prognosis or the burden of a disease. And essentially, it provides a framework of disease and social disease condition interactions. So it means that medical interactions with social circumstances and deprivation are significant, and we need to frame what we're thinking about in this context. In the most recent report, the missing voices, these are the women who died. 229 women died during or up to 6 weeks after the end of pregnancy, 10.9 per giving birth, per 100,000 giving birth, which is 24% higher than the last triennial report, 2017 to 19. 9 women died from COVID-19, and excluding their deaths, 10.5 women died per 100,000, which is 19% higher than the previous triennium. 27 babies died and 366 motherless children remain. So I can't talk to you about Embrace and about maternal death without solidly and with sincerity acknowledging that there are partners and children without mums and sisters and their loved ones. The other part of the missing voices, which is really stark, is most women died in the postnatal period, 6 weeks to a year after the end of pregnancy. And this, we know in maternity services, is a traditionally neglected part of antenatal and postnatal care, or maternity care as a whole. It's sometimes referred to as the Cinderella component of maternity care. After the baby's born, sometimes people take their eye off the ball. I can't also present about Embrace without acknowledging, and solidly once again with sincerity, acknowledging that Black women are more likely to die than white women in pregnancy, similarly Asian women, and they're more likely to have a stillbirth too. More women from deprived areas are dying, and this continues to increase, and 1 in 9 women in the most recent report had severe and multiple disadvantage. So inequalities comes across here really clearly and really starkly. As I mentioned at the beginning of the talk, maternal mortality, we've seen a reduction since 2004, but you can see, looking at it from the direct deaths and indirect deaths, you can see overall it appears to have gone down. But if you look at the end, and we'll do this in a bit more detail, I'll move my slides, you can see that we still haven't got it right. Overall deaths have gone up. You can see blue, which is excluding deaths from COVID. You can see indirect causes have plateaued out, and direct causes have gone up. Selected characteristics. So the team looked at the women who died, and they looked at selected characteristics of these women. What I've done is I've circled or squared previous cardiac problems, pre-existing cardiac problems features. We know about the women that come through combined clinics that have got a Fontan circulation, that have got a coarct repair, that have got a TGA repair. We know about these women. The women that really get into trouble are the ones that don't actually know they've got cardiac disease, and we already know that. But you can see obesity, mental health problems. You can see IVF pregnancy, multiple pregnancy, substance misuse, and then did not receive recommended antenatal care, did not receive minimal level of antenatal care. And this, as you can see, features highly. We all know this. We still feature, though, with cardiac disease. It is still the leading cause of indirect cause of maternal death. You can see here, though, that psychiatric causes sadly have overtaken as a direct cause of death. I won't, for the purposes of today, I don't have time to go into the specifics, but suicides, violent death by teenage mums featured very highly, which is really, really sad. COVID features highly, thrombosis, thromboembolism, neurological, specifically SUDEP, unexplained death of epilepsy, sepsis, other indirect, and then we move down towards preeclampsia, malignancies, and anaesthesia. As I've said before, acquired cardiac disease we know is usually the issue. It's the women that don't know they've got a problem, or they've got acquired cardiac disease that we know about, that they present late or they present suddenly. You can see breakdown here: SADS and MN, morphologically normal heart, ischemia, myocardial disease, and aortic dissection feature highly. Valve disease is still an issue, specifically valve disease that people don't realise they've got, and also pulmonary artery hypertension, systemic hypertension, and a small number of congenital heart disease women. I don't expect you to digest and read through this, but these were the Embrace recommendations from 2016. These were the fresh recommendations at that time. I've highlighted in red things like appropriate maternal medical assessment and screening prior to assisted reproduction, genetic counselling, and cardiovascular risk assessment, making sure that we understand if a woman's got a family history or genetic confirmation of aortopathy or channelopathy, and understanding that that is a significant risk factor. Responsibility of the consultant on call. That's any consultant working in obstetrics and gynecology. Be present, listen, and be ready when somebody comes to you and escalates that there is an issue with a woman. Maternal medicine networks, I've been involved with quite heavily and still am, making sure that the framework and pathways for women in and out of hospitals, tertiary centres and secondary and primary care is robust so that we don't miss anything, and also making sure that red flags such as persistent sinus tachycardia are noted in the maternity setting and also in A&E and anywhere where a woman presents with a problem. So these were the 2016 recommendations. Underneath them, interestingly, was a whole swathe of previous recommendations prior to 2016, and some of them hadn't been implemented. They included things like contraceptive choices, red flag, once again, repeated presentation with pain requiring opiates isn't right in pregnancy or afterwards. It needs investigation, making sure that the emphasis is made on a diagnosis, making the diagnosis for the woman, not just excluding it. Also, you'll see some of the case vignettes if you've read the report of women presenting to A&E with extreme anxiety, breathlessness, and being diagnosed with a panic attack when actually they were having an aortic dissection. They're very sad cases to read. Also, syncope during exercise can suggest a cardiac sign and cardiac origin and needs to be evaluated. ECG and troponin levels are recommended when a pregnant woman has chest pain. Yes, go ahead and do them. And also there was a big push for the use of echocardiogram in any pregnant patient with unexplained or new cardiovascular signs. The second page of previous recommendations, some hadn't been implemented, included things like coronary angiogram and percutaneous coronary intervention is appropriate after somebody has had an arrest with a likely cardiac cause. Electrical cardioversion is safe in pregnancy and is life-saving if instituted at the right time. When aortic dissection occurs in a young woman, assume the diagnosis is inherited aortopathy until proven otherwise. And also, if a woman presents repeatedly and has issues with compliance, getting to hospital, and we're concerned about a cardiac issue in pregnancy, then admit to hospital and make sure that she's worked up and you've reached a diagnosis. Also, implementation of changes to anticoagulation regimen or postpartum as per European Society of Cardiology guidelines. So this slide here was the infographic from the 2016 report where cardiac disease featured highly. I think this is a really useful infographic and I've wheeled it out again and again. As an obstetrician, anybody that looks after pregnant women, I think this is really important. Heart disease can happen. We know this, and you can see 8.5 women died per 100,000 after giving birth from cardiac disease. 2 women per 100,000 died from heart disease. Women are high risk. Persistent breathlessness isn't normal. It's not due to anemia or because the uterus is pressing on something. It needs investigating. Chest pain needs investigating. Need to assume that this is cardiac. And as with preeclampsia, there's good evidence that good care can make a difference. Less than 1 woman in every million now that gives birth dies from preeclampsia because measures were undertaken and changes were made. So my final slide, or my penultimate slide, is this. This is a case that I will read because I will. A primipus woman became hypertensive after a caesarean birth at term for fetal distress, and over the following few days, she had severe abdominal pain, a numb foot, diarrhea, and an ongoing need for analgesia. Staff were aware, but they interpreted it as a cause, as a normal post-caesarean discomfort, and she was not seen by anyone senior or consultant. She was discharged, but was in too much pain to interact with her baby and her family. And 2 days later, she was seen again by somebody in healthcare, by a community midwife. Pain was worse, abdomen bruised, and her foot was numb. GP became involved, but the GP didn't review her. And later that day, she had copious diarrhea and collapse, went to labour ward, in extremis, rectal bleeding, grossly distended abdomen, hypotension, acidosis, and she was taken straight to theatre for emergency surgery, but she died from complications of aortic dissection. And I think I wanted to use this as your final slide or penultimate slide because it illustrates that multiple people were involved, yet nobody thought to make the diagnosis. So my final slide, this is my final slide, is preventing maternal deaths. We are all part of the solution. All of us, every one of us that is in contact with any pregnant woman in any setting needs to be aware of cardiac disease in pregnancy and cardiac causes. So what I'm going to do, because I know people are strapped for time, is I'm going to stop sharing and hand over to my colleagues. Thank you.
Excellent. Thank you, Sarah. So our next speaker this afternoon is Katrin Johnson, who I'm delighted to welcome. She's a colleague of ours from Newcastle. Just while Katrin's preparing her slides, just to remind everybody to pop any questions into the chat. I think we all, I doubt I'm preaching to the converted, but the Embrace report every year makes for fairly sweaty reading, certainly to my mind, and has some really important lessons in there. So definitely it's a must read for everybody. So we're going to move on to really talk about why we see cardiac disease as such an issue during pregnancy, and that starts really with the physiology, and Katrin's going to take us through the cardiac physiology during pregnancy.
Okay, thanks, Kate. Can everybody see my slides and can hear me? I hope.
Yes.
Yeah, okay. So yeah, I think that was an excellent first talk, and it's indeed, it just emphasizes the importance of also understanding the basic cardiac physiology, because it's important we understand this in order to understand how the presence of any cardiovascular disease may compromise the mother and the fetus. So I really want to go through very basic things, and I think it's important that we know the normal heart anatomy and the normal heart function. And I know some of the people in the audience, it's a very mixed audience, and not all of us are involved in cardiology. So just briefly, the heart obviously is a pump, and the pump needs to be filled with blood. The right side of the heart pumps the blood, that gets the deoxygenated blood from the body and needs to pump it to the lungs, where the blood gets oxygenated. That blood goes to the left side of the heart, and the left side of the heart pumps that blood out of the body. So there's one major rule, I would say. The pump needs to be filled with blood, and the blood that goes into the heart will need to be pumped out of the heart. And I think that's very important to keep in mind. Now, the normal heart anatomy, and as congenital heart disease specialist, we see very strange things, but normally the heart is situated in the left side of the chest with the apex pointed to the left. And what can we see in pregnant ladies? Well, the diaphragm is with the fetus growing towards the advanced stages of pregnancy. We can see that the diaphragm is shifted upwards, and we can see that the axis of the heart might change. And so indeed, when we perform ECGs, it's also important to realize that we can see changes that are normal because of pregnancy. And so the one thing is the shift of the axis towards the left axis. We will see fastening of the heart rate, and I will come to that a bit later. And we can sometimes see Q waves in particular in the inferior lead 3. So what about a normal pregnancy? What can people expect during pregnancy? Well, pregnancy is called or named the Nature's Exercise Test. And when I see patients in my clinic and I counsel them, I always kind of tell them, well, you're about to embark on running a marathon. And there are indeed quite some similarities. And the major similarity between a pregnancy and a marathon or any type of exercise is that the cardiac output needs to increase. Now, if we look at cardiac output, and just to emphasize again what this is, cardiac output is the amount of blood that is being pumped out of the heart in a minute. And how is this? How can we calculate cardiac output? Well, clearly we need to know how fast the heart rate is, how many beats per minute, and what is the stroke volume, which is the volume that is being pumped out every single beat. And that's how we can calculate the output. Now, in a normal adult person, the average cardiac output would be around 5 to 6 liters per minute in an at-rest situation. But if we look at people who are like athletic and elite athletes during exercise, the cardiac output can go up to 35 liters a minute, which is, of course, amazing if you think about it. Now, how does, if we talk about exercise and pregnancy being an exercise, I think it's also important to highlight the difference between running a marathon and being pregnant. Now, if we look at the cardiac response to exercise, we of course, there is a focus on the muscles. The muscles, there is a shift of and a flow redistribution to the muscles and the skin. The muscles need to get more oxygen and nutrients, and so this can only be provided or be efficiently done by the heart if the cardiac output, the amount of blood again pumped out, will increase. And if we look at exercise and the response of the heart, well, we see that this is mainly driven by an increased heart rate, and this is proportional to the workload that has been done. And yes, there is also an increase of stroke volume, but again, in a typical exercise, we see that it is mainly driven by faster heart rate. Now, if we look at the pregnancy, the focus, of course, of supply of oxygen and nutrients goes to a growing fetus and the utero-placental circulation. And if we look at the graph on the right here, and we look at the blue line, this is again the cardiac output, which can increase up to 50% of baseline. So it can go, for example, from 4 liter per minute to 6-7 liter per minute. And if you see in this graph, well, yes, the heart rate will steadily increase, and this is progressive throughout the pregnancy, even a bit more towards the end of pregnancy. But the main change in a pregnancy is that the stroke volume will increase. Now, why does the stroke volume increase? So here the trigger is indeed the stroke volume. So if we now look at factors affecting the stroke volume, in exercise again, we can see that there will be the heart rate mainly affecting the cardiac output. Now, stroke volume in exercise will also increase, and this is because of an increased venous return. The muscles are contracting, so more blood is pushed into our pump on the right side, but there will be an increased filling of the left side of the heart. And the main thing, however, in an exercise is that there is an increased cardiac contractility. And this wants to say that with every beat that the heart is contracting, just a bit more forceful and more volume is being pumped out in every single beat. And then lastly, in an exercise, we can see also vasodilatation, so we can see a decreased afterload. If we look into pregnancy, we do not see the increased cardiac contractility, or definitely not to such an extent. The main thing in pregnancy is that we see an increased preload, an increased blood volume. This leads to an increased filling. And the other thing in pregnancy is that there will be also vascular changes. So if we look at this increased preload, the increased blood volume, how does this occur? Well, if you look in this graph and you see again the blue line here, this is the plasma volume. And you can see that in pregnancy, from very early stages of pregnancy, there will be an increase in the plasma volume, reaching about a peak around 24 to 28 weeks, with an increase up to 50% of the baseline. And there are multiple hormones that play a role in this increase of blood volume. However, the main role, I would say, is estrogen-mediated stimulation of the renin-angiotensin system, which gives an increased aldosterone, and this results in sodium and water retention. Now, briefly about what we call the physiological anemia of pregnancy. Well, together with the increase of blood volume and the plasma volume, we see an increased production of red blood cells. However, this is discrepant with the increase. There is more increase of plasma volume than there is of erythrocyte, and this causes a drop in hemoglobin because of hemodilution. And this is what we call a physiological anemia of pregnancy. Now, if we look at the afterload, so what we also see in pregnancy is that there will be a drop in a total vascular resistance, which can be significant, and we can see an increase as well of the vascular compliance, so of the compliance of the wall. So we get kind of a vasodilation. And the reason this occurs is also because of hormones, because of heat production of the fetus, and the hormones involved can be prostaglandin. We know there is a role of relaxin and NO production. So all these have an effect on the vascular wall. Then there is a bit of more debate when we look at the blood pressure, but overall, and in the most studies that have been done, we see a mild drop of blood pressure. And obviously, in the context of vasodilation, this is what we would expect. However, with an increased population of elderly ladies or older ladies above 35 that become pregnant with more risk factors, there are some studies that report that there is not a significant change in blood pressure, and that there even is more a tendency to hypertension. Now, we also need to keep in mind that obviously there is a fetus growing in the belly, and depending on the position of the woman or the mom, the fetus can have repercussion on the venous return as well to the blood, and we can see a reduced preload. So we see a reduced blood volume reaching the heart when the mom is lying on her back with the fetus pushing on the inferior vena cava, and this can be relieved when the mom turns on her side. Now, what happens in labor and delivery? So if we look at labor, we can see again that there is a significant increase in cardiac output. And here I would say the main, that there are two factors, but the heart rate does play a role. And this is because of the lady is now, the mom is performing a proper exercise. She's in pain because of the uterine contractions. There is a bit of anxiety, so the heart rate will increase. But again, we will also see a further increase in cardiac output. Now, the significant increase in plasma volume again is seen immediately after delivery, and this is when we think about the last slide about the compression of the inferior vena cava. Well, when the baby is delivered, that compression will be relieved together with ongoing uterine contractions, and we call this autotransfusion, where volume is pumped into the vessels and reaches the heart. When we look at the postpartum period, well, we see that most of the hemodynamic changes will resolve by the second week postpartum, and a complete return to baseline can take up to 6 months until all the dynamics have come back to normal. So then briefly something about the thrombosis risk of a pregnancy. So in pregnancy, we see that there is an increase in blood coagulation factors. There is an inhibition of fibrinolysis, inhibition of anticoagulant agents, and we know that also together with the compression on the inferior vena cava of the growing fetus, there might be a bit more stasis of blood, and so all of these can lead to an increased risk of forming a thrombus. And we know that the risk increases 5-fold specifically in the 3rd trimester, but we need to keep in mind that there is still a risk post-delivery, postpartum, and this risks can be elevated up to at least 6 weeks after delivery. So again, if a patient presents with symptoms that are suspicious of a pulmonary emboli postpartum, we should keep this in mind and have it checked. Then finally, this is my last slide, I think. So this is important. This is a summary of the changes to cardiac output, the vascular resistance, heart rate, blood pressure, what happens to the volume, the mass, the LV wall mass, the chamber sizes, and the aorta. And I think I didn't went into detail about aorta because I think Justina might mention this a bit later when she's talking about aortic dissection. But I think this is a very nice summary slide to highlight all the changes. So I want to thank you. Let's see if I can get out again.
That's excellent. Thank you very much, Katrin. That's a great run through and demonstrates what hard work it is for these women with cardiac disease going through pregnancy. I like the marathon analogy, particularly the unable to tie up shoes and insatiable appetite is particularly good. So we're doing really well keeping to time. So if people can keep putting their questions in the chat, there are various different faculty members that are able to answer any questions. I'm going to hand over to Kate Gatenby, who is living the dream in Costa in Wakefield. She's one of our colleagues in Leeds. And Kate, we have asked to talk about the really important question, what symptoms are normal and what should raise alarm bells? And this is where lots of people struggle in pregnancy. So over to Kate.
Lovely. Can you hear me all right, Kate?
Yes, we can.
Lovely. So thank you for asking me to talk. And as Kate said, I'm going to be talking about what symptoms are normal. Although actually, I probably won't talk too much about that. What I'm really going to talk about is the alarm bells, the things that we really shouldn't be missing in women who are pregnant. So I'm going to start off with talking a bit about chest pain. Chest pain isn't really a normal feature of any pregnancies, but there are certainly some times that chest pain is more important. And you really should assess a pregnant lady with chest pain in the same way that you would assess anyone else with chest pain. I'm going to illustrate this just with some cases. So the first case is of a 35-year-old lady, para 1 gravida 2, who was 39 weeks pregnant when she presented, and she had no risk factors for ischemic heart disease, but presented 999 with chest pain. And the first thing that most people will have a think about is she's very pregnant. She's only a few days off delivering. Where are you going to look after this lady? And I think the most important thing to remember here is that although she is indeed pregnant, she's presented with chest pain that's so severe that she's had to ring 999 for this. And that absolutely means that she needs to go to accident and emergency. And how are you going to go about assessing the chest pain for this lady? Well, you're going to about assessing the chest pain in the same way that you would do for anyone that isn't pregnant. And the things that are really going to make you think about a worrying underlying cause of this lady's chest pain are, number one, if a woman who's either prepartum or postpartum has rung a 999 ambulance or is presenting repeatedly with chest pain, then that is something that you need to be concerned about. As Sarah already said, if you have chest pain that's severe enough that requires opiate analgesia to treat, there is definitely something wrong. And if someone is coming back and back with repeated presentations with chest pain, you have to wonder what is causing it. Ischemic sounding chest pain is going to sound ischemic whether you have a patient that is pregnant or not. And so if you have a woman who is pregnant, who has chest pain that's constricting in nature, that isn't going away quickly, that's associated with autonomic symptoms, then that is absolutely something that you need to be worried about. And in the same way, if you have a woman who's presenting with pleuritic chest pain that's associated with breathlessness, you need to be thinking about pulmonary embolic disease or pneumonia if they've got symptoms of sepsis. It's also worth thinking about what type of patient you have. You definitely can have coronary disease without risk factors, but we know that as women are getting older and are getting more comorbid when they have their first and second and third and fourth and fifth pregnancies, they will come with risk factors which might make them at risk of ischemic heart disease. So if you have an older, obese woman who's had hypertension and hypercholesterolemia and has a family history of ischemic heart disease, it is very possible that the central crushing chest pain that she has is indeed ischemic in nature. And that can either be atheromatous coronary disease, and I know you're going to have some talks about that later, or the other thing that, of course, can happen during pregnancy and in the postpartum period are coronary dissections. And actually, the patient that I talked about earlier had a coronary dissection of her right coronary artery. And she was treated in very much the same way that anyone else would be treated. She went to accident and emergency. She had an ECG, which of course is completely safe during pregnancy. As we've already talked about on the chat, there are sometimes some slightly abnormal features to an ECG during pregnancy, particularly in gravid women with breast enlargement. The position of the anterior chest leads is often slightly abnormal, so you can sometimes get some subtle anterior T-wave changes. But if you have ST elevation on the ECG of someone with chest pain, that needs urgent investigation whether they are pregnant or not. In the same way that a troponin is a really good exclusive test at excluding coronary pathology or ischemic disease in the non-pregnant patient, it's just as useful in pregnant patients. And if you have chest pain with elevated troponins, then that is something that needs looking into. Of course, pulmonary embolus, if it's large enough, can give you an elevated troponin as well, as can myocarditis, an ischemia or infarction for many cause. I put NT-proBNP in there as well, although perhaps we'll come back to that in a moment. D-dimers are perhaps less useful during pregnancy because they do tend to go up, but a normal D-dimer wouldn't necessarily dissuade me from thinking about a woman presenting with chest pain as having a pulmonary embolus if it was associated with other symptoms. And as we've already discussed, if you have ischemic disease, there are very safe ways that you can treat women who are pregnant with ischemic disease, including angiography if needed. The other thing that always worries people with a pregnant lady with chest pain is aortic dissection. An aortic dissection can occur in a catastrophic manner in patients in the third trimester and often into the postpartum period. So this is a case of a 36-year-old gravida 2 para 1 who'd had an incidental finding of a dilated aortic root with very slight increase during pregnancy, although that's really difficult to assess because the position of your aorta does change as your uterus gets more gravid. She didn't have any of the inherited aortopathy syndromes that might make concerned that she was at risk of rupture. And when she presented at 35 weeks, she contacted a local maternity unit with chest pain that had radiated through into her back, and she was reassured. At 36 weeks, she presented in extremis with an impending aortic rupture to accident and emergency. So how can you tell that? How are you going to pick out those women who've got aortic dissections? Well, again, they usually have very severe pain, severe chest pain, severe back pain. It's often very rapid onset and will tend to present in the 3rd trimester or in the postpartum period. Definitely, this can happen in women who've got known aortic root abnormalities or inherited aneurysmal syndromes, but it can also happen in women who have no predisposing factors to this. Again, if you have someone who has repeated presentations, and this comes up time and time again in the Embrace report, if you have women presenting with repeated presentations with chest pain or breathlessness, it is something that you must take seriously. And as Dr. Winfield said earlier on, it's not just about excluding certain things, it's about getting a definite diagnosis. Yes, reflux disease can absolutely cause chest pain, and if it is typical of reflux disease without any of the other features of an ischemic presentation or a dissection, then it may well be perfectly appropriate to start treating a woman for reflux or gastritis. But if that woman is coming back repeated times and what you are doing is not working, you need to change tack. You need to think about managing it in a different way. So how about breathlessness? To a certain degree, breathlessness can be normal during pregnancy for the reasons that we've just heard about. Cardiac output increases, heart rate rises, you have a gravid uterus, you often are iron deficient, you've got an increased blood volume. It is not uncommon for women to feel a certain degree of breathlessness during pregnancy. And that can be really difficult to assess. I think if you're generally speaking, if you're having women who are having breathlessness that is stopping them from doing their general activities of daily living, or women who can't climb the stairs because they are so breathless, that is breathlessness that you need to do something about. Breathlessness can obviously happen in different positions at night, for example, particularly as you get more gravid. But if that breathlessness is not being relieved with a change of position, or is indeed worse if you are laid flat, that is also something that you need to take very seriously. To illustrate this is a case of a lady who was gravid of 3, para-naught, and she had a BMI of 45. She'd been increasingly breathless since around 26 weeks pregnant. And this breathlessness was attributed initially to being pregnant in the first place. Then it was attributed to her having an elevated BMI. And then it was attributed to her having asthma. But in addition to breathlessness, she actually had really very, very significant peripheral edema. She had orthopnea, so she couldn't lay down. She couldn't lay anywhere near flat at night because she was getting breathless when she laid down flat. And she was waking up in the middle of the night gasping for breath. And those are the things that should really be pointing you in a cardiac direction. So when it comes to breathlessness, again, the same things. If you have repeated presentations with breathlessness and anxiety, if you have breathlessness that is stopping you from doing your activities of daily living, if you are normally fit and active, you should still usually be able to climb a flight of stairs without stopping during pregnancy. Indeed, you should probably be able to climb 2 flights of stairs or 3 flights of stairs without having to stop, although you may feel a little bit breathless at the top of them. Orthopnea and PND, so breathlessness when you are lying flat or waking up in the middle of the night gasping for breath, is never normal during pregnancy. Yes, as I said, if you're lying in an abnormal position, you may feel a little uncomfortable and have to move. And most women are not going to want to lie flat on their back during pregnancy. But if they are breathless when they are lying down, and if they are waking up because they are breathless and needing to sit forwards because they're getting so breathless, that is not normal. And again, if that breathlessness is accompanied by a persistent sinus tachycardia, that is a huge red flag. We'll talk a little bit more about sinus tachycardia in a moment. But if you have breathlessness accompanied with sinus tachycardia, that breathlessness is impinging your daily life, again, you need further investigation. A nocturnal cough is also something that can happen, and I would be very wary about attributing a nocturnal cough to something like reflux if it was in the setting of a pregnant patient who was also breathless during the day. Nocturnal cough can be asthmatic disease, or it could potentially be pulmonary congestion. And if you do have patients who have repeated presentations with breathlessness and anxiety, they've got orthopnea, they've got PND, they've got peripheral edema, then actually you can treat those women and you can look at those women in much the same way that you can look after any patient who you think might have a cardiac cause of breathlessness. An NT-proBNP or a BNP is a hormone that's released from the heart when it's stretched, and it should be normal in pregnancy. So if you have an NT-proBNP that is elevated in pregnancy, you should deal with that in the same way that you would as any other patient. And an elevated NT-proBNP means there might be a diagnosis of heart failure, and you should get an urgent echo for those patients. So an NT-proBNP has a very high exclusion level for heart failure as a cause of breathlessness during pregnancy. So how about palpitations? Your heart rate gets faster during pregnancy, your blood volume is higher, you have increased cardiac output. So palpitations are not infrequent during pregnancy. And we'll go on to talk about some of the red flag symptoms in a moment. But palpitations and arrhythmia can often be associated if you've got a malignant cause for the arrhythmia with collapses. This 32-year-old female presented 3 months postpartum, actually, although she'd had recurrent episodes of collapse during pregnancy. And she had recurrent episodes of collapse that were precipitated by loud noises and seizure-like activity with those collapses. And when she was seen, she had a very long QT interval, suggestive of an inherited channelopathy, and indeed she had long QT2, which is associated with malignant arrhythmias during periods of being startled, or alternatively, when you have periods when you're very tired. So postpartum is a time when women get these arrhythmias. Not everyone with palpitations or collapses will have an inherited channelopathy. But again, if you have palpitations that are associated with severe symptoms, so not just a feeling that your heart is fluttering or skipping beats every now and then, but a sensation that you've got dizziness or you're near to collapse with your palpitations, that is worrying. If you have palpitations with known heart disease, so you have left ventricular dysfunction, which is known, and you have palpitations, the combination obviously is worrying, as is a family history of sudden cardiac death or any palpitations that are associated with syncope. Syncope, of course, is most frequent in women who are pregnant in the setting of vasovagal syncope, but you get a very typical history of vasovagal syncope. And if there are any features that don't fit with typical vasovagal syncope during pregnancy, especially if there's something like a family history of sudden cardiac death, you have to have a high suspicion that there is an arrhythmia. Any broad complex tachycardia should be taken very seriously, and again, repeated presentations. So with all of these symptoms, what we're seeing is if you are having symptoms that are associated with other nasty symptoms, repeated presentations, or family history or risks of malignant cardiac disease, those are red flags. So to finish, the take-home messages that I want you to go away from this with. If you have severe chest pain of any type, that needs investigation and a definite diagnosis rather than exclusion of things during pregnancy. Persistent sinus tachycardia is always a warning sign. Yes, your heart rate will go up during pregnancy when you are walking, but when you are sat down, it should go down. Keep your, look after your woman for a few hours, see if their heart rate deteriorates, see if their heart rate drops when they're sat down. That's what should be happening. If their heart rate is fast all of the time, that's abnormal. Orthopnea and PND are never normal, and you shouldn't be getting syncope during exercise. If you have an elevated respiratory rate, you might feel breathless, but if you've got an elevated respiratory rate, that is abnormal. And those women who've got extreme anxiety associated with their symptoms, you need to take seriously. This will be covered in more detail, but the things that I really wanted to get across is that troponins and ECGs and echoes are all really safe to do in pregnancy and a really reassuring investigation for any of those ladies. Thank you very much.
Excellent, Kate. That's a brilliant talk. I always feel really sorry for midwives. I think they're presented with, a multitude of women on a daily basis, many of whom are breathless with various symptoms that could or could not be cardiac. I think you've given them some great pointers really to point towards what's pathological and what isn't. We've got 2 minutes and I've got a question which hopefully people won't mind me hogging the floor. It's just about BNP. So in your slides you said a patient that was breathless, if you did a BMP and that was okay, well, you then went on to say if the BMP is not okay, to do an echo. So if the BMP is okay and they're breathless, what about if it's valve disease, not myocardial disease?
So, I mean, obviously, you would hope you would have a murmur. I think you would think you would. Yeah, you might not hear it. Again, you know, mitral stenosis, you're probably going to have a high BMP. However, I think what a BMP does is it does allow you a little bit of confidence to perhaps not get an echo immediately. But if you've still got ongoing symptoms and you've got a normal BMP and you've got a woman that's unwell, you've got a test that's telling you one thing and a patient that's telling you something else. In that case, you need a proper diagnostic tool. We see women all the time during pregnancy who have impaired ventricles and still have normal BNPs. Slightly different kettle of fish. But I do think it gives you a little bit of reassurance if everything else is looking normal.
Yeah, absolutely. Excellent. That's great. Any more questions, immediate questions for Kate that aren't going to go in the chat? Otherwise, we shall let her head to her next commitment. Thank you. Right, I think the next talk isn't mine, actually. I'll just check my thing. Yes. So I'm going to talk about the role of pre-pregnancy assessment and counselling. So I will just share my screen. So hopefully that should now be working. So we're going to move on from talking about the sort of presentations that we see in pregnancy to how we manage patients that we know have got cardiac disease before pregnancy. So we've already talked about the EMBRACE report, and these were the slightly depressing findings from the most recent report, which was published just a few weeks ago. And although maternal mortality has been coming down, the overall maternal mortality in the last report has gone up, but the cardiac causes rates do seem to be declining, having been fairly static over many years. The things that we need to look out for, the cardiac physiology, which Catherine has already run through in terms of what changes that we see. And these are the reasons why women with cardiac disease are at increased risk. So they have to be able to increase their cardiac output by 50%, their stroke volume by 30%, their heart rate by 25%. And they have to be able to cope with things like a reduction in systemic vascular resistance and reduction in blood pressure. We know that some of our patients with pre-existing heart disease, whatever that may be, will struggle with those changes. And really, one of the parts of pre-pregnancy counselling and assessment is us assessing whether that particular individual's heart is likely to be able to tolerate those changes which will be demanded of it, i.e. the marathon that Catherine talked about. So how do we stop women with cardiac disease dying? So an increased level of awareness of what's normal and what's not, and that needs to be across the board, really. That's in obstetrics, cardiology, ED, also in primary care and in midwifery. I think that's really, really difficult to be able to tease out what's normal and what's not. And probably we need to slightly lower our thresholds for investigation in terms of patients presenting with symptoms. We also stop them dying by pre-pregnancy counselling and optimisation for women with cardiac disease, whether they're planning a pregnancy or not. So with the best will in the world, even people who aren't planning a pregnancy do get pregnant. So we need to make sure that that is addressed. We need to make sure that women who don't wish to conceive have effective and adequate and safe contraception, and that care during pregnancy and delivery and in the postpartum period, which Sarah very importantly pointed out earlier on, even up to 12 months post-delivery, is still a high-risk time. This is the most recent guidelines from the European Society for Cardiology, and one of their new recommendations was recommended to perform risk assessment in all women with cardiac disease of childbearing age before conception. So how does it work? This is the timeline really for appropriate pre-pregnancy counselling. I'm just going to add a pointer onto this. So this is time going along and pregnancy up here. So congenital heart disease, so girls and young women with congenital heart disease, pregnancy discussions should start at the age of maybe 11 to 13 and should be repeated at every consultation. So we still see patients that transition to our care at around about 16, and sometimes they either haven't or they don't recall having any conversations about pregnancy or contraception in the past, or some of them have got some slightly unusual ideas by the stage that they transition through, suggesting that they maybe are going to have to have in inverted commas a cesarean section, or that there's an absolute no that they couldn't possibly become pregnant. So by the time they hit adult practice at the age of 16, there's quite often already some unpicking to be done. But it's really important that we give patients appropriate expectations about what their reproductive life is likely to look like. So certainly patients in very high risk categories should be warned very early on that pregnancies may not be a possibility, and that they may carry exceptionally high risk. I think that in acquired cardiology practice, it should be normalised that acquired heart disease in women of childbearing age, that discussion around pregnancy and contraception should be the norm in really every consultation. And I think that that's not necessarily the norm. I think lots of that does happen in ACHD and, you know, practices, so sort of valve disease and ICC clinics, but not necessarily some of the ischemic heart disease clinics where patients are generally older. This isn't very often a scenario that doctors are faced with, and sometimes they feel a bit uncomfortable about doing it. But it needs to become much more normalised that we're doing these sorts of consultations at every stage. I think it's really important that for patients who aren't considering pregnancy, that we're making sure that they have appropriate contraception up until the stage at which they're ready or wanting to conceive, and that should be appropriate and safe contraception. At the point where they are thinking about pregnancy, and usually, you know, that's 2 or 3 or 4 years before trying to get pregnant, often patients will go through a risk assessment and a multidisciplinary team discussion. That usually involves a cardiologist, obstetrician, obstetric anaesthetist, plus haematology, if there's a haematology concern, plus or minus genetics if there's a genetics concern, and should involve not just the patient, who I've written down here as mum, but also dad, grandparents and other interested parties. It sort of never ceases to surprise me really that you know, we see the patient themselves. We will often see patient plus mum will come for pre-pregnancy counselling, but quite often the father of this child doesn't really get much of a look in the discussion. Whereas, you know, if there are risks to that mum and that baby, it may be the dad that ends up holding the baby. So it's important that he's involved in these discussions as well. And then patients are, you know, we assess them to be low risk, moderate risk or high risk, and we'll talk a little bit more about that. But even in low risk patients, pre-pregnancy counselling does help. So it facilitates confidence in that patient in terms of their pregnancy. It facilitates care as close to home as possible, so allowing them to deliver locally. It allows them to normalise their pregnancy so that they can manage this, you know, as normally as possible with midwifery-led care. It also allows preconception health promotion and appropriate screening for fetal congenital heart disease if that's indicated. So even in low-risk patients, pre-pregnancy counselling, I think, does play a really important role in normalising really healthy pregnancies. In moderate risk pregnancies, the pre-pregnancy counselling allows us to think about intervention maybe that might reduce a patient's risk pre-pregnancy. It allows them to be aware of those risks of pregnancy, and it also allows us to plan their care to achieve optimal outcomes. So care as close to home as locally as possible where that's appropriate, but also, you know, recommendations about delivery, recommendations about where patients should be seen, so that they go into the pregnancy with their eyes open, knowing what they're dealing with. And then, of course, in high-risk patients, the counselling facilitates intervention again to reduce their risk pre-pregnancy. It allows them to be aware of the risks, and it also allows a discussion regarding other options, so the potential for adoption or surrogacy. And again, care planning helps us to achieve optimal outcomes if pregnancy does proceed. So the pregnancy risk depends upon various factors, and so we use these risk scores, so the modified WHO classification, and then there are another couple of risk scores, CARPREG and Zahara, and we use those to estimate risk, but it still varies from person to person and it should be individualised. And we always look at both maternal risk and at fetal risk, and we estimate mortality and morbidity and try and give that in a format that patients can understand. Now, we also give it in writing. It's quite difficult for patients, I think, to understand, you know, a risk of 1% of dying. So it sounds small. We try and couch it in terms of what the normal risk of pregnancy is, and also that if you're the 1% who dies, then you're 100% dead, not 1% dead. So it does need to be given in maybe in different terms, and often pictorial representation can be helpful. So we're aiming for informed maternal and paternal decision making, and this is definitely a multidisciplinary exercise. So I can talk to people about the cardiac risks, but I will need my obstetric colleagues to talk about the obstetric and neonatal risks, and also our anaesthetic colleagues. It's often not limited to one specific session, and it should be a process, and it should start really in women of any sort of childbearing age. And of course, ideally it occurs pre-pregnancy. Unfortunately, sometimes in my experience, it occurs early on in the first trimester when patients are having a conversation about whether to continue with the pregnancy or not. So patients are classified into the modified WHO score, so WHO class 1, which are low risk, and then WHO class 4, pregnancy not recommended. So WHO class 1, for example, mild pulmonary stenosis, mild mitral valve prolapse, successfully repaired ASD, VSD, things like that. And they will be planned to deliver in their local hospital. Whereas moving up to WHO class 3, these are patients with left ventricular impairment. I think I would argue that mechanical valves should be in WHO class 4, and we'll talk about those a little bit more later on. And things like unrepaired cyanotic congenital heart disease, moderate mitral stenosis. And you can see that here they've estimated the risks of a cardiac event. So if you're WHO class 1, the risks of a cardiac event are less than 10%, whereas in WHO class 4, 40 to 50%. And this classification helps us to estimate to patients their estimated mortality and morbidity. To further assess individual risk, we have to do an up-to-date structural and functional assessment. So we always do ECG and echo, history, lots of exercise testing pre-pregnancy to look at their functional capacity, imaging, BMP, as we've already discussed. And the questions really that we raise are, is the patient optimised for pregnancy, and should any further intervention be recommended prior to pregnancy? Pre-pregnancy genetic assessment can help to assess and inform maternal risk in connective tissue disorders and congenital arrhythmias. It can help assess fetal risk in patients with a family history of congenital heart disease, and it can give a family choices, so using antenatal diagnosis for genetic abnormalities, or indeed pre-implant genetic testing for genetic abnormalities. We occasionally get this, which is difficult, which is people who say, it's all right, we'll see how it goes. If things go badly, I'll have a termination at the point that things go badly. This is pretty challenging. If you look at the cardiac physiology graphs that we've already seen, difficulties often occur around about the time of fetal viability. So this 23 to 26 weeks gestation, which makes really decision making really very difficult indeed. Everybody's trying desperately to hang on for an extra couple of weeks where you may be able to get to the point of fetal viability, but that is really very difficult. And a safe termination of pregnancy at that sort of stage may be extremely difficult to achieve in a patient who's in acute heart failure or has complications related to a mechanical valve. So I think we underestimate, or patients underestimate, how difficult safe termination of pregnancy can be when they're acutely unwell. So just to conclude, The aim of pre-pregnancy counselling is informed decision making by the patient and partner, planned pregnancy care, preconception intervention to minimise those risks, flagging up what complications may occur so that they can be recognised and treated early. But it also allows normalisation of pregnancy as much as possible, allowing patients to have, happy, non-medicalised as much as possible and normalised pregnancies. Thanks very much. I'm just going to unshare my screen. Okay. So just see what time it is. We're doing pretty well for time. Our next speaker, I'll come back and have a look at the chat and answer any questions that are in there. Next speaker, I'm delighted to introduce Ken Hodson, who's a consultant obstetrician at Newcastle. Ken's going to talk us through cardiac medications in pregnancy and the importance of managing those. And we can't hear you if your mic is.
Hello.
Yeah, can hear you now.
Can everyone hear me and see me? I've been having a few problems, I think, with connection because the slides for me are not advancing particularly well. But if there is a problem with my talk, then let me know and I'll find another connection, I guess.
Will do.
So thank you very much for asking me to present. I'm going to be talking about cardiac drugs in pregnancy. I'm a consultant obstetrician who does the cardiology clinic at the RVI in Newcastle, but I wear another hat, and that is the head of the UK Teratology Information Service, which is a service that provides information about medicines use in pregnancy. And I'll talk a bit about that in my talk today. So what I'm going to cover is the pharmacological management of heart failure, arrhythmia, hypertension, and to talk a bit about antiplatelet drugs from a drug safety perspective. I'm going to talk about where to go to for additional information if you need additional information and where you can go for information about medicines use in pregnancy. I've decided not to talk about metal heart valves and anticoagulation, as that's a whole afternoon's discussion in itself. Not to talk about the more obscure cardiac drugs for which you can phone the UK Teratology Information Service for advice. And I'm not really going to particularly talk about dosaging or efficacy of medications. I'm just going to really talk about the indications for the medication and their safety of use in pregnancy. So to give my own service a bit of a plug, the UK Teratology Information Service is based in Newcastle. It provides a lot of useful information about medicines use in pregnancy. If you click on, if you go to uktis.org, it'll take you to our new website, which is much more designed like a BNF really for pregnancy. So I hope that clinicians in the antenatal clinic will find that helpful, and you can search for medicines and it will give you a summary of the medicine and whether it's safe or not in pregnancy. And you can register on the website to get much more information about the medicine and look at the evidence that we've used to form an opinion as to whether the drug's safe or not. I should highlight actually that all of our information sheets are full systematic reviews of the literature. So oftentimes with medicines in pregnancies, you'll get one or two papers that say that the medicine's not safe, and then you might get a lot more evidence that in actual fact, when you use it, it is safe in pregnancy. And it's sometimes difficult to weigh up the evidence, and we take a systematic approach to that and present the evidence and weight the evidence according to methodology, numbers of patients included in the study, etc. So I hope you find that the UK TIS website is useful for you in your clinics. Now, every cardiologist knows that X-ray shows acute heart failure, and the important thing to say about management of heart failure is that you should just do what you normally do. Diuretics are safe to give, opiates are safe, give oxygen, nitrites, beta blocker. These drugs are all safe to give in pregnancy, and you shouldn't delay treatment, particularly if patients are in extremis, because you're concerned about medicines use in pregnancy. And I say this, but oftentimes we see in the Embrace report, and oftentimes we see actually clinically, that people in A&E have been reticent to give medication where medication really does need to be given. And an X-ray like this, I'm sure you'll agree, that needs treatment. If the patient's desaturating, you need to get on and treat the heart failure. So to deal with those drugs in order, so loop diuretics such as frusemide. Now, if you feed rats very high doses of frusemide, you can elicit sort of wavy ribs or rib abnormalities. But in sort of normal human doses of frusemide, there is no evidence that frusemide causes malformation. There was some concern that frusemide might lead to ototoxicity, particularly if given early on in sort of gestations. But actually, a large study of around 1,000 premature babies exposed to more than 28 days of frusemide has not shown that there is a statistically significant risk of ototoxicity. So I think that study basically shows that you can give frusemide without concern. You will have small doses of frusemide in breast milk, but again, that's not at doses that is thought to be therapeutic or harmful to the neonate. So the key message is that frusemide is safe to give in pregnancy and breastfeeding. Obviously, you need to monitor electrolytes, particularly if you've got patients on frusemide for long periods of time. What about the thiazide diuretics like bendrafluozide or bendraflumethiazide and metolazone? Well, there's generally less data on bendrafluozide and metolazone. We've got data on around about 5,000 exposures in the first trimester, with no increase in the reported rates of malformation. There are some case series of neonatal thrombocytopenia, fetal biochemical disturbance, which perhaps you wouldn't necessarily, that wouldn't necessarily be unexpected, because the diuretic does cross the placenta and will also induce kind of a diuresis in the baby. There are case reports of uteroplacental insufficiency, but again, this might be confounded by the fact that the patient needs to be on a thiazide diuretic in the first place, and that therefore, the underlying maternal disease puts the baby more at risk of uteroplacental insufficiency. The sort of biggest study looked at about 1,040 infants given hydrochlorothiazide for hypertension, and that showed no complications in those infants. So the key messages are that you can use thiazides if you need to. We wouldn't recommend it as first-line treatment for hypertension. So although that study of 1,000 infants exposed to a thiazide diuretic were treated for hypertension, it's not part of the NICE guidelines for the management of hypertension in pregnancy. And potentially it would be wise to check the baby after delivery, particularly if the woman's been on thiazide diuretics for long periods of time during the pregnancy. Spironolactone, we quite commonly get asked about spironolactone. Spironolactone is a potassium sparing diuretic, antagonizes aldosterone. It does have some anti-androgenic properties, but those properties are fairly weak. However, sort of when spironolactone was tested with animal testing, and rats were fed quite high doses of spironolactone, it did show that there was feminization of a male fetus in terms of rats. But it is to be emphasized that the rats were fed a very high dose of spironolactone. 40 milligrams of spironolactone in a rat, you can imagine, is a very high dose. And when you look at human cases, there's been no human cases reported of feminization of a male fetus. So it's more of a theoretical concern. And the people that generally tend to stay on spironolactone actually are the liver patients who have got portal hypertension and whom have been on spironolactone often for long periods of time. And generally speaking, I've kept my patients who've got portal hypertension on spironolactone. And yeah, I haven't had many of them, but I haven't seen any feminization of a male fetus in that group. So I think the key message is that you can use spironolactone. It probably wouldn't be my first choice of diuretic, but it is safe in breastfeeding and pregnancy, and that the anti-androgenic properties remain theoretical in humans. ACE inhibitors, most of the audience will know that ACE inhibitors are contraindicated in pregnancy, particularly in the second and third trimesters. In actual fact, when you look at ACE inhibitor use in the first trimester, the question is whether ACE inhibitors are teratogenic. So does exposure in the first trimester lead to congenital malformations? And there's been a number of studies looking at this. The majority of studies, so 4 out of 5 studies, showed that there was no increase in congenital malformation risk in using ACE inhibitors in the first trimester. One study did show an increase in risk, but the ACE inhibitor was used in a diabetic population. And obviously you've got the risks of being diabetic, and poor glycemic control may well contribute to the risk of congenital malformation, as there's a direct correlation between poor glycemic control and congenital malformations. So overall, actually, we conclude that there probably isn't an increased risk of congenital malformation if you're exposed to ACE inhibitors in the first trimester. And for that reason, there's often a question about whether we need to stop ACE inhibitors prior to pregnancy, or patients who are taking ACE inhibitors, say because they have heart failure or because they've got diabetic nephropathy, for example, often benefit from being on an ACE inhibitor. Should they stop their ACE inhibitor prior to getting pregnant, or can they continue it up until the point of becoming pregnant? And I think that the evidence generally is that because ACE inhibitors are not teratogenic, or that you can continue the ACE inhibitor up until the point of a positive pregnancy test. And patients, particularly diabetic patients with diabetic nephropathy, may well benefit from that extra time being on an ACE inhibitor whilst they're trying to conceive. ACE inhibitors in the second and third trimester are a completely different story. So ACE inhibitors affect the fetal kidney. They cause the fetal kidney to stop producing urine, so you get oligohydramnios. And as a result of oligohydramnios, the baby needs amniotic fluid. It breathes amniotic fluid. You get poor lung development, pulmonary hyperplasia. You get limb contractures, and you get problems with the skull bone development. And about 60% of fetuses, if they're exposed in the second and third trimester to an ACE inhibitor, will have long-term renal impairment, renal complications, and about 100% of fetuses exposed to an angiotensin II receptor blocker in the second and third trimester will be affected as well. So ACE inhibitors and angiotensin II receptor blockers should definitely be stopped. And I think they should be stopped at the time of the first positive pregnancy test, if not prior to pregnancy. Can you breastfeed on an ACE inhibitor or an angiotensin II receptor blocker? Well, there is some evidence that these enalapril, captopril, and quinapril have particularly low concentrations in breast milk. And if you read the NICE guidelines for the management of hypertension in pregnancy, enalapril is touted to be the ACE inhibitor of choice for patients postpartum in terms of breastfeeding. There's no data on other ACE inhibitors, unfortunately, and not much data on angiotensin II receptor blockers, although these drugs are quite heavily protein bound, and you might anticipate that they wouldn't be crossed over in breast milk quite as much as ACE inhibitors. So the key message here really is that if you're going to use an ACE inhibitor postpartum, these are the ones for which there is some evidence for, and there's less evidence on other ACE inhibitors. How about nitrates like GTN, isosorbide mononitrate, are all safe and have been used in the past to treat maternal hypertension, have been used as a tocolytic, and have been used to sort of treat a retained placenta. There's no concerns about their use in pregnancy from animal or human data. Beta blockers, again, most of the audience will probably know the association between beta blockers and fetal growth restriction. Some of that it's quite difficult to unpick some of that. So sometimes it's difficult to know whether it's the beta blocker that's causing growth restriction, or whether it's the underlying maternal condition for which you're giving a beta blocker that's leading to the fetal growth restriction. For example, using beta blockers to treat hypertension. Clearly, hypertension increases your risk of fetal growth restriction. So there is this confounding effect, or confounding by indication effect, of beta blockers in pregnancy. And what we recommend is that if you do start patients on beta blockers, that you monitor fetal growth with regular fetal growth scans, and you alert the neonatal team, because patients on long-term beta blockers, sometimes the neonates can have hypoglycemia postpartum as a result of being exposed to maternal beta blockers for towards the end of pregnancy. Calcium channel blockers, there's little data available actually on most drugs except nifedipine. So there's a lot of data on nifedipine, but very little data on drugs like amlodipine. So we tend to look at them as a class. So there's no increase in miscarriage rate and no increase in malformation rate. However, you can see that the data that we've got is pretty low actually in terms of number of exposures. There doesn't seem to be a difference between fetal growth restriction in terms of rates compared to women on labetalol as a comparator group. Nifedipine is okay for breastfeeding. Amlodipine is probably okay, but we have very limited data on that. And then we talk mainly about all other antiarrhythmic drugs. Some of these drugs are actually given to pregnant women in order to treat the baby. So if you've got a fetal SVT, for example, then we use sotalol and flecainide, and digoxin can be used to actually treat the baby. Almost all of the antiarrhythmic drugs are safe to give in pregnancy. There's no evidence of harm, although the actual numbers of patients in whom we've got good data on is very limited. We suggest that we try to avoid amiodarone if possible. Particularly long-term treatment with amiodarone can affect the fetal thyroid gland, causing fetal thyroid problems. So if you can avoid amiodarone, it's a bonus. But all the other antiarrhythmic drugs can be used, including adenosine if you want to terminate a fetal arrhythmia, a maternal arrhythmia. These are all safe to use in pregnancy. We're very familiar with aspirin in obstetrics. We're giving it out to lots of people. Low-dose aspirin is safe, and there's widespread evidence to support that. We use it to reduce the risk of preeclampsia for those at high risk. So you can get approximately 63% risk reduction of preeclampsia if you give it to a high-risk population who are under 16 weeks. And this ASPIRE study has sort of caused us all to, we used to prescribe 75 milligrams of aspirin, and now we've gone to 150 milligrams of aspirin as a result of this ASPIRE study, which is one of the only studies that's shown a reduction in preterm preeclampsia, and is therefore thought to be a significant study. So that's kind of influenced quite a lot of obstetric practice. We often get asked about clopidogrel. There is actually fairly little human data on a clopidogrel. There's no real warning signals coming out or red flags that clopidogrel is harmful in pregnancy, and I tend to say to people, well, if the indication for using clopidogrel is significant and you want to continue it during pregnancy, I think it's probably okay to do so. To mention warfarin, warfarin embryopathy. Warfarin is a known teratogen. It does affect up to 10% of patients who are exposed to it, particularly in the early phases of pregnancy, so between 6 and 9 weeks gestation. Causes nasal and facial hyperplasia, stippling of the bones, feeding and breathing problems. There is some evidence that that relationship is dose dependent, and some study has shown that low dose warfarin, less than 5 milligrams, is associated with much lower rates of warfarin embryopathy. Warfarin not only crosses the placenta, but gets super concentrated in the baby, so the baby's much more anticoagulated than the mother. And if you do use warfarin in pregnancy, and sometimes we do, then you do have to be aware of that if you're an obstetrician delivering the baby, because you need a washout period of about 2 weeks for the warfarin to reverse in the fetus. The concern about warfarin fetopathy is bleeding, essentially, particularly intracerebral bleeding for the baby. And the risk of that's quoted between 1% and 2% of patients taking warfarin. There's almost no information on DOACs, However, there is some sort of more concerning animal model data which suggests increased risks of miscarriage and sort of problems with fetal growth restriction. So generally speaking, DOACs are not recommended for use in pregnancy. So to summarize, most cardiac drugs are safe in pregnancy and breastfeeding, and the exceptions are ACE inhibitors, angiotensin II receptor blockers. You need to consider carefully whether you're going to put a patient on warfarin during pregnancy, and try to avoid amiodarone if you can. Manage patients as if they're not pregnant. Medication safety information requires careful interpretation, and if you need help or you want advice about medication use, then please do contact the UK Teratology Information Service. Thank you very much.
Thanks very much, Ken. That's a great run through, and it's always comforting to know that we carry on giving out our beta blockers through for many, many women in pregnancy, much to kind of quite a lot of people's upset, but it doesn't ever really seem to cause any clinical issues. And similarly for the antiarrhythmics, we continue those in patients who've got well controlled arrhythmia problems during pregnancy, so that we can keep the mum safe, because without a safe mum we don't have a safe baby. So we are doing really well for time. Thank you very much, Ken, for that. Hopefully you'll be able to stay and see if any questions come up in the chat.
Yep.
I'm delighted to introduce Claire Bogue, who is our next speaker, who is consultant midwife in maternal medicine for the North East and North Cumbria network. These are new roles that are being developed around the country, and are really important for doing exactly what Claire's title says, so normalising the obstetric experience in women with cardiac disease. And we're delighted that Claire's able to join us today. Hopefully she is, and the strike has not pulled her away.
Hi, Kate, it's Terry. Yes, I don't think Claire's managed to attend, but she has sent through a presentation, which I'll start.
That's great, thank you. I'm not hearing anything.
Can you not hear it?
No, can you?
I can, yeah.
It might be to do with the settings on your thing. Can you try and...
I'll just pause that.
Oh no, we've had this before.
Might be something in audio, might there?
Yeah. Can anyone else help with is it to do with settings on the device settings to play the audio on the MP4?
Can you hear that?
Yeah, but not clearly. Let's try again.
Can you hear that, Kate, or not? No.
No. Someone's put in the chat, when you share screen, you have to share audio. Oh, so when you go into share screen, Terry, when it says share content, there's a little slider that says include computer sound at the top. So if you come out of share screen.
Oh, I turned everybody else off there, I think, as well. I couldn't hear you, sorry.
Can you hear me now?
I can, yeah.
So come out of share screen.
Yep.
And go back into share screen. And it should say share, when at the top it says share content.
Oh yes, include.
And then
oh,
include
right.
computer sound. Just put that
Apologies.
slider
Yeah.
on.
That's me. I got that wrong. I'll just start that again.
See if that works.
Good afternoon, and thank you for inviting
Yeah,
me
just
to
turn the
come
volume
and
up.
talk at this meeting about
That's
normalising
working.
the obstetric
Brilliant.
experience in women with cardiac disease. My name is Claire Bogue, and I'm the consultant midwife for maternal medicine at Newcastle Hospitals. So I wanted to give you a little bit of background, first of all, about my role and how this links into the care of women with cardiac disease, because I think it'll give you a little bit of context. And I'd also then like to talk a little bit specifically about the role of the midwife, just in brief, and then build that up as to how that influences and contributes to the holistic care of women who have cardiac disease. So just very briefly to begin with, a little bit of background about where we are nationally with maternal medicine services for women who are pregnant. So we are responding currently, in my role, it is new to the Trust and also new across the North East and North Cumbria clinical networks. And we're working towards a vision where maternal networks are established across the UK, and there are 17 of them. And obviously we form one, the North East and North Cumbria. Within that, we have our regional maternal medicine centre, which is here at the RVI. And as part of our maternal medicine centre, we provide an excellent service here within our joint obstetric and cardiology clinics over at the Freeman Hospital. So within those clinics, we have consultant obstetricians and also specialist cardiologists. And that's very much in line with what we're called to do from a broader maternal medicine perspective, where we have consultants in obstetrics working with other relevant physicians to provide appropriate antenatal care and labour and delivery care for women with complex needs. And it also relies on a system where we have early referral to a multidisciplinary team. So midwifery within that context of the multidisciplinary team, I'm aware that a lot of you here possibly may not be overly familiar with the role of the midwife. So just very briefly, a little bit of information about that. So the role of the midwife is around basically providing universal midwifery care to all women. And that's broken down into a number of categories. And they are, this is actually a copy of a table relating to midwifery as a role that was published by the Lancet series and is part of our professional standards for midwifery proficiency. And it's about the organisation of care, the values and the philosophy that midwifery espouses to, and the care that we bring to women. And obviously for women who have medical complications, it's recognised that their needs are additional to those who require universal care only. So basically midwifery is about skilled and knowledgeable, compassionate care for childbearing women, and that includes obviously newborn babies and families, and it's about care through the entire pregnancy continuum. So that can be from preconception care right the way through to when the baby is 28 days old. We're about optimizing normal processes in pregnancy, and this is for all women. So thinking about not just the biological processes, but also psychological, social and cultural processes. And that's throughout reproductive and early life. And it's important that we work with teams to ensure timely prevention and management of complications for women. And we do this by consulting with and referring to other services who can support the care of women during their pregnancy journey. And fundamentally, we're about respect for women's individual circumstances and their views. And we aim to work in partnership with women to strengthen their capability to look after themselves and their families. And I'm sure some of you may be aware of midwifery itself, or the word midwife actually means with woman. So it's about working with the woman to meet her needs. So within the sphere of complex care, the midwife has quite an important place in terms of providing continuity of care to women and coordinating some of the maternity care that's required. Currently, we're in a situation where maternity care is being transformed, and continuity of care is a key theme within that. And certainly for the care of women here within our cardiac clinic, we've been able to provide a degree, or I've been able to provide a degree of continuity for very complex women. And we've seen the benefit as they have moved through their journey. And it's about focusing on the fact that although they may have cardiac disease or other medical complexities, that they're also, you know, generally a relatively young woman who is undertaking a life-changing event, who's about to become a mother, for whom many this will be a once-in-a-lifetime event. And it's about not losing sight of that in amidst the diagnosis and all of the medical care that needs to happen in order for the woman to remain safe. So within that space, the midwife is about being an advocate for the woman. It's about ensuring that care wraps around her and her family across that entire continuum of pregnancy, but also really about focusing on the positive expectations of pregnancy. As I said before, you know, for women, this is about you know, a life-changing event, about becoming a family. And for many women, they're very anxious about their pre-existing medical condition and how that will impact on their pregnancy. But there are other women that we care for who choose not to think about their medical complexity when they're pregnant and want to focus purely on having a baby. So we have to balance that out as a team and support women and give them appropriate information. But sometimes some of the things that we'll do for women just to make sure that their care is holistic is think about their previous birth experience. If it's not their first baby, sometimes they need to go and talk about their previous experience when they become pregnant again. It sort of comes back rather, so we can refer to birth reflections for women who've had a very traumatic experience. Maybe you know, it may potentially have been something to do with going to theatre for a cardiac reason, nothing to do with having a baby, but they may have some anxieties now that they're pregnant about birth. So we can refer to our trauma clinic, and we obviously have a broad selection of mental health services and a mental health support midwife here, breastfeeding services that we can tap into to try and give that more normal experience to women. But fundamentally, it's about supporting a safe and personal journey for the woman, being kind, professional and family friendly in the care that we provide. So specifically for women with cardiac conditions, I mean, we know that the transition to parenthood is a sensitive time for women, and when professional support needs to be available. And, you know, often when I'm in the clinic, I can talk to the cardiac specialist nurses about women, and you know, we can discuss, you know, additional care or support that might be required. But also from a midwifery perspective, it's sometimes about exploring early on what the women's perceptions and experiences are, and trying to understand that so that we can provide for their needs, you know, and make sure that we personalize their maternity care based on not just their pregnancy, but also their pre-existing cardiac condition. And for women who have heart disease, it's likely that their care will span our community services and also acute clinical settings. So they're likely to have scans and appointments at the hospital. They're likely to see the obstetrician, the cardiologist, but they're also likely to carry on and see their community midwife. And often it's really good to have that relationship antenatally for women with their community midwife. It's good for professionals to be able to communicate and have that contact point, but it's also really important that that's maintained so that the woman knows her midwife when she comes to visit her after she's had her baby. So it's really important that we collaborate and share information across all areas of the care, and that's sort of again where the community midwife comes in, so that again we can wrap the care around the women and their families and understand you know, their personal differences and how we can support them with that and through that. So in terms of collaboration in maternity care, we know that that can have a positive impact on the health outcomes and also on women's personal experiences, and we do focus in on experience of care now, not just in maternity, but we know that it's very important that women do have a positive experience, and you know, we don't want women to be stressed and worried and anxious when they're pregnant. It's not good for them, and it's not good for the developing baby either. And focusing in on the maternal and child relationships really important too, particularly, as I said, you know, for women who maybe are very anxious about their cardiac condition and how that will impact on pregnancy. So we want to talk to women during their journey about the relationship they have with their fetus, about bonding, the transition to parenthood. And often it's nice to be able to provide midwifery support ongoing for these women if their babies are admitted to our neonatal intensive care unit. And sometimes, unfortunately, as well, when women suffer a bereavement, that continuity of care and having known the woman through her journey and understanding how that has looked sometimes can be helpful. But we know nationally there is some variation in the organisation and management of care for women who have pre-existing cardiac conditions. And there's some evidence as well that there's a lack of qualitative evidence about women's experiences in this area, and that's something that we're looking to gather locally through some research that we've been talking about here in Newcastle. So communication is also really important in terms of normalising the experience. That's communication, obviously, with the woman and her family, explaining what's going on in terms of cardiac care and how that fits in with routine antenatal care, if you like. And collaborating often also in my role with not just the MDT colleagues within our sort of medical sphere, but we do often have to engage with multi-agency colleagues, and it's really helpful to have that midwifery input and the continuity that brings through the journey in terms of referral to children's services and understanding and navigating safeguarding processes, referrals for mental health, and for example, supporting women who have additional requirements due to their learning disabilities. So it's important that we'll have those systems in place so that we can support all of the women that we care for. And also being a midwife means that I'm able to direct women to information that helps them to make informed decisions about their care. And we're also always promoting equality and diversity in the care that we deliver to try and make sure our services are accessible for all women, particularly those that we know they have difficulty with access. And it might be that, you know, signposting women to specific things based on their specific circumstances is required. And an example of that would be around, you know, looking at support for travel costs for women. But the really nice thing about being a midwife within the care team for women with cardiac disease is that I have time to sit with women, talk to them about their personalised birth plans. Then that's obviously runs alongside the plan that's made in view of the medical complexity. And often women do require a little bit of support at birth, and if ever I get the opportunity to go to a delivery, that appears to be quite well received by women, but also, you know, that's also very nice for me as a midwife. So, you know, wherever I can, I do try and do that. And it's really important that we have those discussions with women about their contraceptive choices moving forward. And that's a lot easier to do if you know somebody quite well. But it also, having a midwife within our team means that I can act as a direct point of contact for women, and then a conduit between the medical teams, and it just keeps the care sort of fluid, if you like. And you know, this is all essential. Good communication is essential as we coordinate the care for these women, to ensure that, you know, we ensure safe delivery for them of their babies, and to make sure that they make it safely through their pregnancy. So relationship building is really important for positive engagement, and we hope a positive experience for women. I think, you know, we have good relationships within our team, and understanding and respecting each other's roles. Again, there is some evidence sort of broadly that there's a lack of structure around multidisciplinary working, and when pre-existing medical teams sort of come together. But we know that women, you know, who have a care team around them who listen to their needs with professionalism and humanity are likely to feel much more enabled to take control over their choices, and especially when those women have vulnerabilities. But in relation to cardiac disease, you know, we're interested in trying to improve shared decision making with women. And it's easier to do that when we have a good understanding of the women's social context, what our personal goals are, and our values and healthcare preferences. And that helps women to sort of develop an understanding of the problems, and it helps the team to collaborate in a way that means the plan of care is acceptable to the woman. So again, you know, the role of the midwife is very much around public health, prevention, and thinking about later life as well, particularly for women with cardiac disease. So we're very focused on stopping smoking if possible, breastfeeding, thinking about mental health, reproductive health, and safe family spacing is also really important for these women, as is, you know, healthy maternal weight, reducing rates of alcohol, and encouraging women to access all of the immunizations that we would like them to have. So just in summary then, normalizing the obstetric experience in pregnancy for women with heart disease is about providing all women universal midwifery care and optimizing these normal processes that I've spoken about across the continuum of pregnancy, from, you know, pre-pregnancy ideally right through to when the baby's 28 days old, and any additional care as well, obviously, that women need due to their medical complexity. And it's about meeting the physical, the psychological, social and cultural and spiritual needs of women with heart disease. It's about understanding those and making care plans that recognize, you know, where women are and what they want and what their hopes and expectations are for their pregnancy. The midwife is an integral part of the MDT, and referring and collaborating with other health and social care professionals is really important. And as I said, this element about wrapping care around the woman, which is a lot easier to do if you've got some continuity in the system, and continuity of care, you know, we feel is the way to providing women with a sort of optimal experience during their pregnancy. But fundamentally, as a midwife, you know, my philosophy and my aim is to focus on a positive pregnancy journey for these women. Thinking about future motherhood, you know, I'm very fortunate to work with a brilliant team of obstetricians and cardiologists here, and while we're focused on getting these women safely through their pregnancies, you know, we want these mums to see their children go to school and live a happy and fulfilling life and family life, and we want them to stay well long term. So thank you very much for listening to my presentation. I'm sorry I couldn't be there in person, but I've added my contact details here, so if anyone does have any questions, I would be delighted to hear from you. Thank you very much for listening.
Oh, that's excellent. If Claire listens to the playback, I think that she'll be delighted to see all the big love that's coming out for these specialist midwifery roles in the chat, and also like to say a welcome to Natalie, who is a similar role in Yorkshire and Humber, who I think is now on as well. I've just spotted her. So we're by design just a few minutes behind. It gives we're going to restart at 3 o'clock, so it gives everybody just 15-20 minutes to stretch your legs, get the blood running back to any cold extremities, and grab a cup of tea. And after the break, we're going to look at some of the high risk lesions, and then we're going to talk through 2 cases with a team from Newcastle and then a team from Leeds, just really to highlight the sort of slight differences that people face in terms of some of the physical setups of how care is delivered, and just to look at some of these more challenging cases. So quick cup of tea, and then we'll restart at 3 o'clock. Thank you. Are you in a clinic room, James?
Yes.
Did you have clinic all morning?
Yeah.
Did many come?
It was. They all came.
Good.
So that's a good thing.
It's obviously very well heated there. You've only got a shirt on.
Oh, it's really nice. Well, I've had the door closed. As soon as you open the door, the main outpatient area is quite cold because it keeps opening and closing, and that's freezing.
Yeah.
You need jumpers on out there, but it's all right here. Are you warm at home? Well, you got your.
Well, we have the heatings on, but it's still blooming freezing. It's because I'm sat still, so I've got about 6 jumpers on. But I've discovered that with a blanket on my legs, I'm now a bit hot.
You need a heated one.
I know, yeah. I need a little hot water bottle for my feet is the only thing. Yeah. Right, it's 3 o'clock.
Yeah.
Okay, so it's 3 o'clock. So we're going to carry on with the programme. So the next part of this session is speaking about high risk lesions. So these are the things that we come across that people need to really worry about. So I'm delighted that James Oliver is one of my colleagues in Leeds, is able to join us today from doing his outreach clinic in Sheffield. He's going to talk to us about pulmonary hypertension. Take it away.
Okay, thank you, Kate. Right, hello everybody. Let me just let my Mac get up to speed. You should have slides.
Yes, have slides.
Lovely, fantastic. So, pulmonary hypertension. Just 10 minutes on this, and I'll get on through. That's if I can change the slide. Yeah, so I'm just aware that not everyone will know exactly what pulmonary hypertension is. So here we go back to basics. So this is the right heart, okay? So blood is coming in from the veins into the right atrium, through to the right ventricle, and then from the right ventricle, it's pumped out to the pulmonary artery, okay? And from there, it heads off to the lungs. And what we're interested is the pressure in the pressure of this pulmonary artery, and the normal pressure is less than 20 millimeters of mercury. So pulmonary hypertension is quite easily defined as pressure of greater than 20 millimeters of mercury. And essentially, pulmonary hypertension is a disease of the very small blood vessels of the lungs, the very small arteries. So just at the top, you can see an artery here, which is thin-walled with a very wide lumen. That's the normal situation. Blood can get through that nice and easily. And then across the bottom, you can see a progressively histology of a progressively more abnormal small pulmonary arteries. So the walls become thicker and the lumen reduces. And you can imagine it's going to be very increasingly difficult to get blood through those arteries. It's not a single disease. There's all sorts of causes of pulmonary hypertension. If there's no underlying identifiable cause, then it's idiopathic or primary. Congenital heart disease is a fairly common cause of PH. Chronic pulmonary emboli is another cause, but there are lots and lots of other potential causes. So if you've got pulmonary hypertension, what does that mean? Well, what it means is that the right ventricle that's pumping blood to the lungs is under a lot more pressure. It's pumping against this high pressure, so it has a lot of strain on it and is at risk of failing. And then there is a reduced ability for the right ventricle to increase the amount of blood it pumps to the lungs at times of increased demand. So it's difficult to increase cardiac output. And this means that patients are breathless, have palpitations, may cough blood, are at risk of syncope and signs of right heart failure. How do you treat it? Well, there's various groups of drugs that you may or may not be familiar with. These are the 3 main groups of drugs here: PDE5 inhibitors, such as sildenafil or tadalafil, endothelin antagonists, the first of which was Bosentan, and prostacyclin analogues, such as iloprost. And these all basically work by working on those very small arteries of the lungs and increasing their diameter, so facilitating flow. In terms of prognosis, well, that very much depends on what the cause of pulmonary hypertension is, if one can be found, and how severe it is. But to give you some idea, with current treatment in those with primary or idiopathic pulmonary hypertension, the mortality is around 20% after 3 years. What about pregnancy? So you can imagine that you have a right heart that's under an awful lot of strain, and then you add all of those demands of pregnancy. And those normal physiological changes then present a major challenge to women who have pulmonary hypertension. Or potentially, you may even unmask previously undiagnosed pulmonary hypertension. And that's because there is essentially this very limited ability to accommodate the increased cardiac output, an inability to cope with the volume load of pregnancy. The resistance of the pulmonary circulation usually falls in pregnancy, but that fall is either attenuated or absent. The right ventricle can become ischemic, and there's an increased risk of thrombosis. So historically, the outcomes were dreadful. And so if you go back, so this is looking back at the historical outcomes in PH, and you can see that in the kind of 50s to 70s, certainly in a kind of congenital population, there was a 50% risk of death in pregnancy. Fast forward through to the 80s and 90s, that's fallen a bit to the 40s. And then in the late 90s to early 2000s, about a quarter of women who are pregnant with PH die. Don't worry about most of the detail in this table, but if you look on to the right, this is the experience from the team at Sheffield, published in 2017, who have, I think, the biggest cohort of patients. You can see they've got 36 patients, of which a quarter had terminated, 20 deliveries, and you can see they had, in this cohort, 2 deaths. So that's a rate of 7%. And in all of their cases, right at the bottom, you can see they were treated with pulmonary vasodilator drugs. So in terms of managing pulmonary hypertension in pregnancy, these are the principles. So clearly, pre-pregnancy counselling, very clear, needs to be established from an early opportunity, clear contraceptive advice. And then once pregnant, it's all around very detailed clinical assessment, aggressive pulmonary hypertension drug treatment, involving all the right professionals at the right time, and very detailed, individualised planning. So to give you an idea, this is their published protocol. So patients with a suspected diagnosis of PH go undergo the standard diagnostic pathway, which may include a right heart catheter. Or if a patient with known PH becomes pregnant, they're reassessed with imaging and possibly another right heart catheter. And then you've got all the information you need to try to come to an assessment of what the risk for that individual is, and then present that to the patient. And then decide whether the pregnancy should continue. And if it does, then early institution of treatment with, for example, sildenafil or iloprost, as well as some low molecular weight heparin, adding in pulmonary vasodilators as clinically indicated, frequently monitoring the clinical status of the patient in terms of exercise capacity, imaging, and also, of course, the growth of the baby. And then electively admitting patients from around 36 weeks, usually planning a cesarean with a combined spinal epidural, with all the right people in attendance at the time of delivery. And then very close postpartum monitoring and critical care with invasive hemodynamic monitoring and also non-invasive cardiac output monitoring. Now, I don't know this patient, I'm afraid I've nicked this from the team in Sheffield, but this is just to illustrate. This is a 23-year-old with idiopathic pulmonary hypertension who is not bad. So has WHO functional class 2, so is not too limited by her disease, is stable on Busentan and warfarin, is apparently warned about the teratogenicity of Busentan and seen by a gynecologist for contraception. Don't worry too much about the details of this right heart catheter, but essentially, essentially what this shows is that the PA pressure is elevated, but not too bad. She's not in overt heart failure. She's a reasonable cardiac output. And her pulmonary vascular resistance is elevated, but not desperately so. But she then has a threatened labour at 24 weeks, and is given steroids, and a few days later has a collapse and cardiorespiratory arrest while she's an inpatient, at which point IV iloprost is started, and 5 days later she undergoes a cesarean and has a successful outcome. But this is the hemodynamics that I mentioned in the previous slide that were quite favourable, and you might think she would be relatively low risk. And this is the point at which she collapses. And you can see that the PA pressure has gone up considerably. The RA pressure indicates that she's in significant right heart failure. The pulmonary vascular resistance has gone up, and the cardiac output comes down. But 5 days later, on aggressive treatment, those hemodynamics are much better. So the moral of this story was that even those patients you think are pretty good with pulmonary hypertension doesn't necessarily mean that it will all be okay in the end. So really, I think all I want to do is summarise that, saying that pulmonary hypertension is really only managed in major centres such as Sheffield. Even when in our congenital heart disease service, if we have serious pulmonary hypertension, we'll be talking and asking for patients to be managed in Sheffield for our region, because the cases are very high risk, admittedly not quite as high risk as they once were with modern treatment, but it always is important they're managed in an expert centre.
Excellent. Thank you very much, James. They're always terrifying. I have a great slide with a nice picture of David Kiley on, because I always send ours to him. But the Newcastle team don't have that luxury, do you, Justina? Yours are presumably all managed in Newcastle. You're muted. Justina, you're muted still. Oh, there you go, you're on. Can't hear you though. Oh, she's gone. So any questions about pulmonary hypertension, just please, if you can put those in the chat. Justina is meant to be doing the next section on aortopathy. She seems to be having a problem with her connection. So what we might do is move on, and I'll do the mechanical valve. Oh, she's back. Is your connection working? No. So Justina, I will put some information in the, if you write a message in the chat, I'll go do my mechanical valves talk. If you can then see if you can get your connection to work for your aortopathy. So one of the other high risk lesions, which actually, as we mentioned earlier on, doesn't classify itself as a WHO class 4, but you'll see from these slides that why I kind of think it should be. So this is about mechanical valves in pregnancy. So just an overview really of what we're going to talk about. Why is it a problem? What happens when it all goes wrong? Why on earth do we put mechanical valves in the first place? What's the size of the problem? And just a couple of cases to think about. So the reason that mechanical valves are an issue is that mechanical valves can develop clots. So they get clots form on them, and they require lifelong anticoagulation. If a mechanical valve develops a thrombosis or a clot on it, the consequences of that can be catastrophic. Of course, you all know that pregnancy is a prothrombotic state, therefore increasing the likelihood of a thrombus forming during pregnancy. And unfortunately, there is no perfect anticoagulant during pregnancy. So Ken has already touched upon this and discussed a little bit about warfarin, and we'll touch a bit more on that. So the two anticoagulants that we use during pregnancy are really warfarin and low molecular weight heparin, with unfractionated heparin kind of really having gone out of favour. Of course, the other side of this discussion is that the obligatory anticoagulation that we require for mechanical valves increases the risk of the patient bleeding at the time of delivery. And that's something that clearly for midwives and for obstetricians and for patients is a very big problem. So this is a systematic review which is published in 2017, looking at 46 papers of 2,500 pregnancies. And so they describe a maternal mortality in patients taking warfarin of 1%, low molecular weight heparin 3%, a thrombus or embolic complication rate in low molecular weight heparin of 9%, and on warfarin 3%. Major bleeding rates 12% low molecular weight heparin. And live births 92% on low molecular weight heparin, but only 65% on warfarin. And what I think is always important to do is to look at compare these mortality rates with the UK maternal mortality, which is 0.01%. So if you compare 0.01% to 3% maternal mortality, we have plenty of patients say, oh, that's not too bad. Well, to me, that's really pretty terrible. And also, Ken's already touched on this issue, which is this dose dependency with warfarin. So there is a view that potentially a patient that's on 5 milligrams a day of warfarin or less has a higher live birth rate and a low fetal anomaly rate. Some people argue about that data. This is UK data, so the UCOS system, which you'll all be familiar with. This is about mechanical valves, and this is surveillance data between 2013 and 2015, and they documented 58 women. 71% were on low molecular weight heparin throughout, 5% on warfarin throughout. Importantly, 19%, so 1 in 5, were not referred to a tertiary centre or to specialist cardiac obstetric clinic, and half of them didn't have documented pre-pregnancy counselling. In this series, only 28% had a good maternal and fetal outcome. There were 5 deaths, which is a maternal mortality rate of 9%, 41% serious maternal morbidity, and 47% had a poor fetal outcome. So this is really terrible data. I suspect that there may be a reporting bias in here, but really dreadful outcomes in the UK in this time period. So just a little bit more about warfarin. So the data really, to my mind, is very clear that warfarin is safest for the mother with a mechanical valve, but there's a very high early miscarriage rate. It runs the risk of embryopathy, which we've talked about, also the risk of fetopathy and an increased rate of late pregnancy loss. Warfarin is very easy to take. It still has to have an INR checked, and we usually would check it at least every 2 weeks during pregnancy. And the most recent guidelines would suggest additional aspirin on top of warfarin. Whereas low molecular weight heparin, I think, is sadly seen as a bit of a panacea, and it's really, really difficult to take low molecular weight heparin properly. The doses required in pregnancy are really high, so they're much higher than the standard dosing. The dosing in pregnancy is BD, and the doses that are required are quite unpredictable, and they change during the pregnancy, and they're different from patient to patient. So we start with a weight-based protocol, a weight-based dosing, but it very frequently needs changing. We have to do frequent anti-10A levels, and we do peak and trough, which for the patients is pretty terrible. So they have to come before their first dose in the morning, have their blood taken, and then hang around. They take that dose of low molecular weight heparin and then hang around for 3 to 4 hours. Particularly in patients that carry on with the low molecular weight heparin throughout pregnancy, they get lots and lots of site discomfort related to the BD dosing. There's a major issue about pharmacy availability of higher dose syringes. So we've occasionally had some poor people who end up having to use 2 syringes to get the dose that they need. So they're on 4 injections a day. And if low molecular weight heparin is subtherapeutic, there's no backup. All you can do is increase the dose and wait for the levels to come up. Whereas with warfarin, at least we can give them some low molecular weight heparin and give them some extra anticoagulation. So I think it's difficult that low molecular weight heparin is not really necessarily the answer. This is our experience. I've just recently updated this slide. So between 2006 and 2022, 33 pregnancies, including 1 twins. Most of our MVRs have had sequential dosing, so changed to low molecular heparin in the first trimester and then gone back to warfarin, but 1's taken warfarin throughout. And interestingly, this lady's husband works in a clinical trials unit and had looked at all the papers and decided that they should continue with warfarin. Most of our AVRs are low molecular weight heparin and aspirin throughout. 2 intrauterine deaths at greater than 20 weeks, 1 warfarin related, and no cases of warfarin embryopathy. There have been 20 completed pregnancies and 21 live births, including one set of twins. We've had 10 thrombotic events, 5 hemorrhagic events, 1 acute surgery for a thrombosed mitral valve, and no maternal deaths. We've had 5 that have been uncomplicated. And I think that the thing to say about these pregnancies, they're all highly medicalised, and it's incredibly dependent upon patient and doctor factors. 2 more are currently pregnant, and are continuing with our theme of the more complex the patient, the further away from us they live. So even with, you know, a very committed medical team, this is very difficult to get right. Not all valves are the same, so we don't have a hard and fast protocol. So valves that are in the aortic position, a nice decent sized valve, patients in sinus rhythm, and it's a bileaflet modern tilting disc type valve, are a very different story from a mitral valve, a small one of these old-fashioned Starr-Edwards valves, which you occasionally still see patients with atrial arrhythmia. So this end of the spectrum are far more likely to get a thrombus form on the valve, whereas this end of the spectrum are at lower risk, but still not low risk. So what happens when it goes wrong? If you get clot on the valve, that can obstruct the normal movement of the valve leaflets, and the valve may then not open or close properly. The valve will become obstructed or regurgitant, and the patient will usually present with significant breathlessness and tachycardia, usually clear changes on a chest X-ray and on an echo. They can present acutely with complete cardiovascular collapse if the valve is stuck completely closed or completely open, and can just present with sudden death. Or if they've got clot on the valve and the valve's still working okay, but bits of clot are thrown off, then this will embolize into the systemic circulation. The presentation will therefore depend upon the site of the embolus, so they can present with stroke, myocardial infarction, or peripheral emboli, obviously into the limbs or to other organs or to the eyes. So why on earth would we choose a mechanical valve? They have good points. So they can last a lifetime. It reduces the number of operations that a patient will require in a lifetime because they last such a long time, and that can reduce their lifetime risk. And they also have a larger effective orifice area than most of our tissue valve prosthesis. So if we're struggling with sizing, a mechanical valve is often the only way out. Tissue valves have a shorter lifespan, especially in young patients. Average lifespan of a valve with a good enough function for pregnancy is probably only about 6 to 8 years. And it absolutely commits them to further surgery when they're older. But the benefit of a tissue valve is clearly that no anticoagulation is required. But this is a patient, this isn't actually the patient, but a patient who transitions to adult services at the age of 16, a repaired atrioventricular septal defect, had an initial operation, which was the first stenotomy, which was a pulmonary artery band as a neonate, followed by a complete repair. Stenotomy number 3 was a redo left AV valve repair at the age of 6. Stenotomy number 4 was a further redo left AV valve repair at the age of 12. And she comes through at 16 with severe left AV valve regurgitation and symptoms, is unable to participate in PE at school. She's planning to do her A-levels ×3 next year, hoping to go to university to study dentistry. So her valve clearly needs something doing. What do we do next? So we're unlikely to get a good result at a valve repair. She's already had 3 attempts. She needs a valve replacement. When you think about tissue versus mechanical, she's already on her 5th stenotomy, but she's going to go to university and do dentistry. She's not likely to have her children for at least another 10 years. But if you use a tissue valve, that's not going to last you long enough to get through her pregnancies. So she's really got little option but to go for a mechanical valve. TAVI in aortic disease may give us another therapeutic option, and there are transcatheter mitral valves coming through the pipeline, but they will cause trouble of their own. So in conclusion, therefore, pregnancy with a mechanical valve in situ is high risk for mother and baby. Thrombotic valve complications can be absolutely catastrophic and are extremely challenging to treat. Obviously, we have the complications of a fetus in situ and a mother with tissues that have been affected by pregnancy, so their risks from surgery are significantly higher. The management of low molecular weight heparin is very challenging for patients and for doctors, and I think that we underestimate this, how difficult this is for people to get right. It is possible to get good outcomes for mum and baby, and we should never forget that. But even if you have immaculate management of anticoagulation, we still do see complications, unfortunately. So that's all I really have to say about mechanical valves. They shouldn't be managed in anywhere but expert centres, and it's kind of beholden upon us to get that message out, really, because it's still not completely known out there. Thank you. Okay. Justina, are you set with your link?
Yes, is it now sound working?
Sound is now working, yes.
Okay, perfect. Apologies for technical issues.
Excellent. So you're going to talk about aortopathy.
Yes.
Is that right? Yes, excellent.
Share my slide.
Kate, you do have one question in the chat if you want to answer that while Justina loads her slides.
On the Paranox, isn't that just another low molecular weight heparin? Am I being dim?
Apologies, but you know, it's some privacy issues because of the recording that I cannot share.
Justina, you want me to go first? And then you
Yes,
can...
yes, sorry. Yes, please.
You want me to go first?
Yes, please.
So
that'd be great. So Katrin,
yeah.
you're going to talk about heart failure.
Yes. Give me 1 second to share my camera and okay. Yeah. Okay, so yeah, I'll start off and then Justina can check the mechanical aspect. So just to start with, I think we should realize that heart failure has got multiple mechanisms because often people associate heart failure just with an impaired ventricular function, so an impaired pumping function of the heart. But however, there's other mechanisms such as volume overload, which could be in the context of a shunt in congenital heart disease, a leaky valve like the one that Kate just presented with her case, pressure overload because of obstructive lesions, and we will present a case later on, pulmonary hypertension, as James has mentioned, and then poorly controlled arrhythmias, diseases of the pericardium. And if we look at the definition of heart failure according to the European Society of Cardiology guidelines back of 2021, it's important that we realize that heart failure can also occur when you have a normal ejection fraction. And this is in particular in patients who have a stiff ventricle, so again, where the filling is impaired, diastolic dysfunction. But obviously, heart failure can occur with either mildly reduced or in particular with severely reduced ejection fraction. Now, if we look at this pie diagram, we can see that about here 23% of patients, ladies that are seen in an obstetric cardiac clinic, present with cardiomyopathy. And I would say that this pie diagram probably reflects what we see in our clinic. So there is a big bulk of patients that have actually a proper myocardial disease. But still, we need to be aware that heart failure can occur with any of these. And it is very important that we are aware because these need different treatments, of course. So when it comes to myocardial dysfunction and cardiomyopathy, more and more we will see, or we are seeing already, patients who presented with ischemic cardiomyopathy, who had a previous infarct where a part of the muscle is not working, and they of course need also ongoing surveillance with relation to coronary artery disease. And then, of course, we've got that bulk of patients who present with cardiomyopathy. And I think it's important, again, that if we talk about cardiomyopathy, you have primary cardiomyopathy, which can be acquired, genetic or mixed. And again, the majority of people probably that we see of pregnant ladies have dilated cardiomyopathy. But there's also secondary causes of cardiomyopathy. And I'm not going to go into detail, but just it's important to know, because we need not only cardiologists or obstetricians, but sometimes we need people from other disciplines involved in a meeting. And again, this is all about which therapy can we continue in pregnancy, what does the patient need as therapy for its underlying disease that causes the cardiomyopathy. And then I just want to briefly mention something about peripartum cardiomyopathy, which is an idiopathic cardiomyopathy of which we do not fully understand the pathophysiology. Probably there might be some myocarditis, viral infection, definitely a cytokine-mediated inflammation, and just simply an abnormal response to the physiological changes that I just mentioned in pregnancy. And there seems to be also a role of excessive prolactin production. And there is the role of bromocriptine as a treatment option, and I'll briefly mention it later on. So these patients often present with heart failure secondary to LV systolic dysfunction towards the end of the pregnancy or still in the months following delivery. And it's a diagnosis of exclusion where no other cause of heart failure is found. And this is not always easy, because sometimes, of course, a patient can have dilated cardiomyopathy, which was not diagnosed before, and where the pregnancy unmasks this diagnosis. However, we usually see that peripartum cardiomyopathy recovers. It can take a while until the function fully recovers. It can take up to 2 years, but in the majority of cases, we will see full recovery. And it's important that we do not too rapidly taper the heart failure therapy in these cases. And it's also important to be aware of the risk, the recurrence risk of peripartum cardiomyopathy in a subsequent pregnancy. And this is determined by the ejection fraction at the time of the subsequent pregnancy. So we know that patients who have an ejection fraction lower than 50% are at a significantly increased risk of developing again heart failure, and even for mortality in pregnancy. So obviously we can be aware of the cardiomyopathy when the women presents with in pregnancy, or and here of course pre-pregnancy counseling is crucial, and Kate has mentioned this in detail. Or of course we can unmask a previously undiagnosed cardiomyopathy, or a patient can present with peripartum cardiomyopathy, and it is very important, of course, that we recognize the problem in a timely manner. So what about management of patients with cardiomyopathy? Well, it's crucial to do a proper history taking. Is there any family history of dilated cardiomyopathy? Have you previously been treated for anything? Has there been a cancer treatment, etc.? Clinical examination, of course, and obviously symptoms. Does the patient present with symptoms? And as previously mentioned, orthopnea and PND is never normal in a pregnancy. So then clinical examination looking for signs of clinical heart failure. Is the patient has the patient got crepitations in the lungs? What is the blood pressure? A lower blood pressure in a patient who looks unwell, and we need to have a low threshold for further investigations. And further investigations include an ECG and a TTE in the first place. And I think what we're looking for at the echocardiogram, and again, it's not only in the context of diagnosis, it's also very important in the context of surveillance of ladies with cardiomyopathy. So we look at the ejection fraction, we look at the dimensions of the ventricle. Is there any secondary valvular problem, valve blockage, and is there any secondary pulmonary hypertension? And obviously the main risk factors are a low ejection fraction, less than 30, and presence of pulmonary hypertension or right heart failure. And when it comes to an ECG, not always patients feel that they are in an abnormal rhythm. So if there is presence of an atrial fibrillation, that is also a risk factor for a poor outcome. So the role of BNP or NT-proBNP has been previously discussed as well, not only important in the diagnosis, but we need to be aware that a normal NT-proBNP or BNP does not exclude an underlying cardiac disease. However, it is very important because a normal level of BNP or NT-proBNP during pregnancy in women with heart disease it predicts a low risk of adverse maternal cardiac events. Now, this has been shown already, this diagram, and it's just highlighting that patients with impaired function, either moderately impaired function or severely impaired function, well, these are patients who require follow-up in an expert center. Also patients with previous periportum cardiomyopathy, either without or with residual left ventricular impairment. These are patients at higher risk. And obviously, symptoms play an important role as well, whether the patient has symptoms related to the heart dysfunction or not. And just my slides are not as fancy as James' slides, so just to show here that in dilated cardiomyopathy, for example, with a patient with severely impaired function, as shown here on the echo, why do they not tolerate pregnancy? Well, because of the increased volume. The ventricle does not cope with this increased volume because it is impaired. We will see that the filling pressures will increase. Secondary, the filling pressures in the upper chamber in the left atrium will increase, and then we will start to see secondary pulmonary hypertension. And as a result, the patient will go into cardiac failure with prominent pulmonary edema, and this is of course a big issue. Now, the periods of increased maternal risk is obviously towards the end of the second trimester, because then the peak hemodynamic changes have occurred. Usually, if the patient has tolerated the pregnancy very well until then, we would not anticipate any major issues in the last trimester. However, again, at the time of labor and immediately post delivery, we still need to be vigilant because there still is an increased risk of decompensation. So again, just to show the adverse events, and in the very high risk group here with patients with an ejection fraction of less than 30 with or without symptoms or previous periportum cardiomyopathy with residual LV dysfunction, well, there is a significant increased risk of adverse events or mortality, and these patients should be advised against a pregnancy. Contraception needs to be discussed, and we should even consider termination if they are pregnant. When it comes to heart failure management, and I think Ken has been through this in more detail, I think the management goals have to be similar to non-pregnant patients who present with heart failure. We should avoid phytotoxic agents, and again, ACE inhibitors, ARBs, the newer medications like Entresto or MRAs. Should be avoided. Diuretics and furosemide, as Ken has mentioned, it is safe. We have many of our patients on these treatments, but they should be avoided if a patient is in stable cardiac cardiomyopathy, but stable with no clinical presentation of pulmonary congestion. We should avoid them due to the potential reduction in placental blood flow. And then finally, hydralazine and nitrate should only be used in the presence of hypertension, severe LV dysfunction, and or again evidence of congestion in decompensated heart failure. There is a role of bromocriptine because of this potential involvement of prolactin when it comes to periportum cardiomyopathy. And I think important when we talk about delivery, of course, the focus goes to the mom. If a patient develops acute decompensated heart failure, we need to consider early delivery. And obviously, this can be very traumatic if the fetus is not viable, or even if the fetus is viable but still in a very early stage, it can be traumatic to the mom. And an urgent delivery is needed if the patient presents with cardiogenic shock, and this is best done with a planned cesarean section. And obviously, otherwise, all the other heart failure management is similar to regardless of pregnancy. So in summary, I think I want to highlight the importance of preconception counseling and early recognition of symptoms. There should be a low threshold for echocardiogram and NT-proBNP or BNP. We need to consider early termination in high-risk patients, in particular when the ejection fraction is less than 30 and when a patient presents in symptoms, and medical heart failure management or mechanical support even as appropriate, and urgent delivery via C-section in patients who present in acute cardiogenic shock. Thank you.
Excellent. Thank you very much indeed. That's great. So these patients are fairly common, I think, in both practices, both Leeds and in Newcastle and in all the other big centres across the region. We're going to try and see if Justina's managed to sort out her presentation. She actually looks frozen on her screen at the moment. Let's see.
Can you see my slides?
Not just now.
No. And can you hear me?
I can hear you, but I can't see you
No.
or your slides.
Because I'm reading, that should be now working. But of course, if you are not seeing this, that's not good at all. And you still cannot see the screen.
It's black for me anyway. Is it for anyone else?
Yeah, I can't see it either, Justina.
Sorry. I'm not sure.
I'm going to try turning your video off because it's using some of your bandwidth as well. And your picture quality is not very good. Alex.
Hello.
You sound like you're in a plane.
I have a helicopter flying over my head.
Do you want? Can you do your sudden cardiac death channelopathies?
I'll try. I'm just apprehensive it's all gonna.
Wow.
Just keep sharing the screen now. Can you see that?
Yeah. Yes. Thanks. So we'll do this section first, and then see if we can get Justina's aortopathy talk to load. So Alex Sims is one of our other cardiologists who runs the obstetric cardiology service, and Alex is going to talk to us about sudden cardiac death and channelopathies in pregnancy. Thanks, Alex.
Thanks, Kate. Good afternoon, everybody, and thank you for having me talk today. So I'm going to talk about sudden death and channelopathies in pregnancy. Is that moving? Just to double check.
Yes.
Fantastic. So, so what's the definition of sudden cardiac death, or what we tend to talk about, sudden arrhythmic death syndrome, SADS? So clearly it's the SAD, sudden unexpected death. Sometimes it's a sudden aborted cardiac arrest, but unfortunately many of these patients do die, and there's often no clear cause on post-mortem or following toxicology screening. And it is assumed, therefore, that the cause of death is a lethal arrhythmia. Now, the causes that we know about are often ion channelopathies, which I will talk about in a bit more detail. Cardiomyopathies can sometimes present in this manner, but you'll note this is more electrical disease, and that's prior structural heart disease developing in cardiomyopathy, so very early forms of the conditions. And then there are other syndromes, such as Wolff-Parkinson-White has about a 1% mortality rate, and that's often thought due to AF with pre-excitation, leading to ventricular fibrillation, and in some cases arrhythmogenic MVP, although that may be more structural. But actually a large proportion of patients who have a SADS or who die with unknown cause continue to die with unknown cause. We don't often know what that is. We'll find out what's caused that through family screening. And you know, there's a big unknown still, I think, in these patients. So just looking at some stats of those patients across the UK that died suddenly and unexplained back in sort of 1907 to 1909, study by Elijah Bear from George's, looked through these deaths, and about 115 deaths across most of the UK, and concluded actually 50% of those deaths were true SADs. That is, there was no explanation. The other 50% did have explanation, and therefore the mortality prevalence, or the rates of mortality from SADS, is about 0.16 per 100,000 patients per annum. And now, Why is that relevant? Well, we've seen already by the EMBRACE report that cardiovascular disease is a major cause of maternal mortality for the last report, and has been for many years. And when we actually look at the causes...
Alex, can you just reshare your screen?
Something happened.
Yeah,
it just jumped out there.
Yeah.
Can you see it now?
Yeah, thanks.
Don't know what happened there. Anyway, and you'll see from the causes of cardiovascular deaths, the same time period, that almost a fifth of those who died from cardiovascular deaths was related to SADS. So this is a fairly topical and relevant point in pregnancy. So why is pregnancy maybe, well, we know pregnancy is an arrhythmic state, and this is just a slide highlighting that some of the reasons why. So the increasing volume that we've discussed already today causes atrial and ventricular stretch, and that sets up a scenario of electrophysiological changes within the tissues that risks or increases your risk of arrhythmia. Larger hearts, for example, also might be able to sustain re-entry arrhythmias more, and there's some mouse models, for example, that suggest the hormones of pregnancy may be more pro-arrhythmic. So pregnancy is potentially a pro-arrhythmic state, which I think we probably all recognise. And again, we're just going back to the causes. So the causes of arrhythmias and causes of sudden death can be cardiomyopathies, and the three commonest are hypertrophic, dilated, and arrhythmogenic, but I'm not going to talk much about them because I'm going to talk more about the ion channelopathies. And the commonest are the top three here: long QT syndrome, Brugada syndrome, and catecholaminergic polymorphic VT, or CPVT for short. But there are clearly others here that are extremely rare that we occasionally see. But really there's very little data in pregnancy on these cases. So what about long QT syndrome? And I'm going to go through these fairly quickly because I've only got 10 minutes. So long QT syndrome is the commonest of all the channelopathies, accounts for about 1 in 2,000, 1 in 5,000 cases. The cutoffs for QT interval, which is your repolarization period of the cardiac cycle on your ECG, is different from men and women. It's one of the only inherited conditions that probably has a high yield for genetic testing. So about 7 out of 10 patients have a genetic gene change that we see. Most of the forms are autosomal dominant inheritance, but there are some recessive forms. And there's a slight difference in presentations between males and females. To date, over 15 subtypes of long QT syndrome have been described, but the vast majority are accounted for by long QT1 and 2 and 3. And they often present recurrent syncope or cardiac arrest, or sadly sudden death. When we look at the mutations, they often involve mutations of the sodium and potassium channels of the myocytes, which affect the action potential. Both the KCNQ1 and the KCNH2, equating to 1 and 2 long QT syndromes, cause mutations in the potassium channels that limit the expulsion of potassium from the cell and prolong the action potential, which increases your risk of arrhythmia. The SEM5A mutation, which accounts for the long QT3 form, causes a rapid, larger influx of sodium in the initial phase of the action potential, which again increases your action potential, increasing the time for which an arrhythmia can occur. The treatment's relatively simple once the diagnosis is made, is a beta blocker. As we've heard in pregnancy, that's not a bad drug to have to hand. ICDs help to lower risk and can be used. And then if you're still getting symptoms or breakthrough arrhythmias, left cardiac sympathetic denervation can be performed and other medications can be added in. So what about long QT syndrome in pregnancy? Well, actually long QT syndrome in pregnancy isn't that different in terms of risk or event rate compared to those patients who are non-pregnant or the pre-pregnancy phase. It is actually the postpartum period that seems to have a highlighted risk of event rates, and that potentially goes on for about 9 months. And you can see from the bar chart here, which is a combination of syncope or aborted cardiac arrest or death, that the postpartum period is significantly more frequent, has a much more frequent occurrence of these events than any other area that they've looked at here, so pregnancy and the longer postpartum period. When we look at long QT syndrome then by type or phenotype, we see again that the generally the postpartum period is more frequent in terms of event rates, although maybe in long QT3, pregnancy has a slightly higher event rate. But you can see that long QT2 patients have a much higher event rate in the postpartum period than the other areas. And we don't really know why that is, but that is the type of long QT syndrome that responds to sudden, you get arrhythmias related to sudden stimulus, so phones or babies crying maybe, and as also you're more predisposed when you're tired. So potentially setting, in that postpartum period, that is, those things are quite common, and potentially that is one of the reasons why it's more common in pregnancy, in the postpartum period, as opposed to pregnancy. What is reassuring is, and really important, and the one thing we always highlight with our long QT patients, is that keeping on your beta blocker in a postpartum period seems to lower your event rate significantly compared to those who don't take their beta blocker. And again, you'll see that here in the bar charts, that the postpartum period off beta blocker patients have a much higher event rate. So what about Brugada syndrome? Well, this is rarer. It's about 1 in 5,000 patients, a relatively newer diagnosis or newer described syndrome. It's mainly autosomal dominant inherited. The commonest mutation is the SEM5A mutation, and there's sometimes overlap with long QT3, but in this scenario it counts for about 20 to 25% of cases. But then the vast majority of patients with Brugada don't have mutations. The risk is of sudden death. Patients with Brugada syndrome do present often with syncope. They seem to have a lot of vasovagal episodes. They can have bradycardia as well. Those who are deemed high risk are sometimes a bit difficult to identify. They tend to be male, so females tend to have a more protective effect. They tend to have a spontaneous type 1 ECG. Those who have a history of syncope are high risk, and those who have very fractionated or very spiky QRS are also thought to be higher risk. There is a risk with fever, so we advise patients with Brugada to treat fever aggressively, paracetamol, ibuprofen, get into a cold bath, get to hospital if you can't get your fever down, and there's avoidance of specific medications. If they're high risk to get an ICD, there is no real therapy for this. Quinidine can be used for breakthrough arrhythmias, but there's not much evidence behind it. The Brugada is an interesting arrhythmic condition. It tends to concentrate mainly in the right outflow tract of the right ventricle, where there's a high burden of SEN5A proteins and sodium channels, and basically you have a spatial dispersion problem with the electrics that allows arrhythmias to propagate, and you get this typical coved J point elevated 2 millimeters elevation and coved ST segment change that you can see here. And it can either be diagnosed by having a spontaneous version of that or a provoked version of that, often using a sodium channel blocker drug called Agmalin. But what about Brugada in pregnancy? Well, this is very reassuring, but again, very limited data, unfortunately, for Brugada syndrome. So observational trial of 104 women with Brugada delivered about 219 babies. 3 of them prior had an ICD. None of them had an arrhythmia during their follow-up and pregnancy. 4 had aborted sudden cardiac events, and again, none of those had any events during pregnancy. 24 patients had a prior syncope, and as I said before, Brugada syndrome has a high incidence of syncope, but only 6 patients during the pregnancy had a actual blackout, and no arrhythmia at that point was clearly identifiable. And then at a 2-year follow-up, 2 patients that follow up over a year had ICD shocks, but clearly they've already got ICDs, and these patients are already known to be high risk. So I think, in short, pregnancy with Brugada syndrome is generally quite safe. I think it's important that we know about them and that we manage certain aspects like specific drugs, which I'll come to in a sec. What about CPVT? Again, this is rarer, further, about 1 in 10,000. You normally have a resting ECG, normally have a structurally normal heart. This condition leads to ventricular arrhythmias with exertional emotional stress. It can be inherited in a dominant fashion with the ryanodine receptor gene, or recessively with the calcinquestrin 2 gene, which is much rarer. And treatment is initially with beta blockers, sometimes with flecainide. Again, left cardiac sympathetic denervation can be used, there's some debate about the benefit of ICDs, and also lifestyle advice would be to restrict exercise in many cases. And you see here on the ECGs I have to the right here that you have an increasing level of ectopy coming in, and bifocal ectopy or bidirectional ectopy, and then in increasing exercise, and if that was allowed to propagate, they would start to go into VT or polymorphic VT. So what about CPVT in pregnancy? Also, again, not much data out there. Observational study of 96 women. Most interestingly, most of these patients were diagnosed after their pregnancy, so they went back and had a look, and not many of them really needed much treatment or events. There were 5 syncopal episodes. There was 1 aborted cardiac arrest, but interestingly, none of them at the time were on beta blockers, so they weren't actually treated for their condition. So I think the conclusion really was that CPVT, if it's recognised and it is treated, it is probably reasonably safe throughout pregnancy. But again, being aware of it and knowing about it, I think, is the key. So general management principles for those 3 channelopathies. I think education, particularly about triggers, long QT, particularly postpartum. Make sure you're on your beta blocker. Try to get good sleep. Try to keep well hydrated. UNEs, other electrolytes are important in long QT as well, because your QT interval could be affected by them. So making sure that they're okay, and especially if you're vomiting and not able to keep any food or substance down. For both long QT and Brugada, there are specific medications that you are recommended to avoid, and you can either go to www.credible-meds.org for long QT drugs, or www.brugadadrugs.org for Brugada medications that need to be avoided. In pregnancy, we tend to keep an eye on the long QT patients every 2 to 3 times throughout pregnancy. We maintain them on their beta blockers throughout, and if they have a prolonged QT over 500 in pregnancy, I tend to start them on a beta blocker, and we keep their ICDs going on, unless obviously at time of delivery they need to be turned off, and we arrange that locally if need be. Brugada syndrome really is not much, I think, different in pregnancy. Obviously, not many patients in pregnancy drink or take cocaine, so that's useful. There are options for catheter ablation, potentially Brugada, if they have resistant ventricular arrhythmias, but again, that's not something we would likely entertain in pregnant women. CPVT is about trying to avoid strenuous exercise, stay on their beta blocker, modify. Sometimes you can use a modified exercise test to assess their risk in pregnancy. You can use flecainide, but again, left cardiac sympathetic denervation in pregnancy is probably not something we would entertain. And you can use phenylephrine rather than adrenaline or noradrenaline if you need to during pregnancy, or to keep blood pressures up if patients are suffering or hypotensive. And when we talk about particularly making plans for pregnancy, I think that's key with these patients. I think most of them go through pregnancy without problem, but I think that's partly because they're well recognised and they have good birth plans, and we advise what things to continue and what things to avoid. So in terms of acute VT, that's very uncommon, but for long QT, temporary pacing, either lidocaine, possibly amoxicillin are useful. Brugada is a slightly strange one for acute VT breakthrough, because isoprenaline is the known treatment for that, or obviously cardioversion if possible. And CPVD, again, IV beta blockers, flecainide possible, and cardioversion potentially, but they're often quite hard to get out of VT. If in labour, they recommend here in this recent publication that you should telemeter, but that's quite difficult really on a labour ward. I don't think that is a very safe mechanism, but you may want to consider if they've got a history of difficult to control ventricular arrhythmias. Epidural anesthesia for long QT is useful because that dampens down the pain, the adrenaline response, which is one of the triggers for arrhythmias, and normal vaginal delivery is often favoured in that situation. And again, the same for Brugada. The problem with Brugada is there is guidance to avoid bupivacaine, lignocaine, and propofol. I think they are, certainly bupivacaine and lignocaine are difficult to avoid if you want to use an epidural. I think ropivacaine has some evidence of being safe, but and the argument is when it's intraspinal or in epidural, the systemic absorption is quite small, and potentially the risk to Brugada patients is quite low. And certainly we've used epidurals in Brugada patients without any adverse outcomes. If you have CPVT, it's very rare. I think I can remember one patient we've delivered with CPVT she's had 2 deliveries, in fact, and all went very smoothly. Again, that's really about managing pain. Epidural will be quite useful in that situation. You want to try and reduce the stimulation and the pain to reduce the stress on the heart and the risk of arrhythmias that they pose. And then post-delivery, I think it's important that these patients are monitored, because that's certainly in long QT. That is obviously where arrhythmias do occur. I think it's really important to make sure they stay on their beta blockers, and breastfeeding, as we've seen, is safe with beta blockers. And it's also a point to note that these are potentially inherited conditions, and therefore the baby or the neonate is potentially at risk of these conditions and potentially needs screening at the time. In fact, taking blood off the cord for genetic testing can sometimes identify them at risk, in particular long QT syndrome. That's something that we would advocate, because that's something we can potentially treat at an early age. So very, very, very much a quick overview there. I think sudden cardiac death is quite rare. Ion channelopathies are also very rare in pregnancy. In terms of the overall cohort, I think obviously in our specific links we see particularly a lot of long QT syndrome. I think you need to be aware of the potential risk, but most of these patients are actually relatively stable if they're well recognized and managed. And you need to have an eye on those patients coming through clinics also might have a family history of SADS, because these things need to be looked at, and we potentially take patients or mothers through pregnancy with a SADS history in the family, or first degree relative particularly. They do need a combined approach. Birth planning, I think, is really important here. Beta blockers pretty much for all, although bear in mind they're not great for Brugada syndrome, and postpartum follow-up and arranging follow-up is key to make sure they stay well. Thank you very much for your time.
Excellent, thank you, Alex. That's great. I'm going to put a question just in the chat in a moment about this, and obviously anyone else with questions, Alex will answer those in the chat. So we're hoping we're just a few minutes behind. I'm hoping that Justina may have managed to sort out her IT issues. Yes, looks like it. Hopefully we can hear you as well, Justina, when you unmute.
Okay, can you see the slides now?
Yes, and we can see you and hear you.
Perfect, all right. So it has been mentioned on several occasions from earlier in the afternoon that aortopathy is a significant risk factor for pregnant women, and also Catherine discussed in detail what happens, what changes happen in the circulatory system in pregnant patients, but all of this, so including increase in sympathetic activity, activation of the renin-angiotensin aldosterone symptom, which lead subsequently to increased heart rate, blood volume, and cardiac output, together with the altered hormonal status in the form of increased levels of estrogen, progesterone, and also oxytocin postpartum, lead to modifications, changes in the aortic wall structure, and that's very much about the hypertrophy, hyperplasia of the muscle cells, and fragmentation of the reticulin that surrounds elastic fibers, and that's all in the medial part of the aortic wall. With all of this happening, that leads to the disorganized structure of the elastic fibers, which causes increase in the aortic diameter and also compliance, and the highest risk of that happening is in the third trimester and also in the postpartum period. So the most dangerous and the complications that could be potentially life-threatening that we are afraid of is obviously aortic dissection. Clinically, in practice, we usually use terms of type A and type B dissection. Type A, it's when the dissection, the tear and dissection starts in the proximal part of the aorta, and it can either be contained just to this area, so to the aortic root and ascending aorta, but it can also progress to the distal part of the aorta. And type B aortic dissection is when it starts in the distal part of the aorta. What are the symptoms that patients may experience? So it's the most common symptom is the chest pain, that it starts usually abruptly, and it's severe in nature. Often it radiates to the back, to the interscapular region. Patients may also experience abdominal pain and neurological symptoms, and that's or related to the possible ischemia of the abdominal organs and or limbs. Often on presentations, the blood pressure is elevated, and there might be also the difference in the blood pressure between the arms. Of note, one of the symptoms also in patients, specifically in patients with the Marfan syndrome, is that they may have aortic regurgitation on presentation. That's most common in the Marfan patients than the others. So what's the epidemiology of the aortic dissection? So overall, it's a rare complication in pregnancy. As you can see, it's occurring only in 0.0004% of the pregnancy, but the risk in pregnancy is 4 to 25-fold higher than in the non-pregnant state. And most importantly, the maternal mortality is up to 30% of the women that experience a dissection. And also there are very high